Good morning. How is everybody? Good? You're fine. You're fine. Okay. So welcome to week 3. Only 3 classes left after today. Good. What's that? There is. So, nope. 8 classes. So we've already done 4. Today is 5. So there's only 3 after this. Over the weekend, you guys had chapters 5 and 6 to read and do the questions on. 5 is important because it's on dementia. And we have, it's okay. Hey, Jake, can you get her some paper towels, please? He'll grab them for you. Okay, 5 is on dementia, and we are going to be taking care of a lot of dementia patients throughout our career. I want to explain the difference between Alzheimer's and dementia because this gets a little bit confusing for students. So the best way to understand this is if I stand up here and say I'm sick today, that tells you I'm not well. But it doesn't tell you anything specific, right? It doesn't mean that I have a headache. It doesn't specifically mean that I have a stomach ache. It doesn't specifically mean I have an upper respiratory. It just means I'm not well. So the term sick is very, what we call unspecified, very generalized. Well, the term dementia is the same thing. Dementia just means not well, but specifically cognitively or in the brain, thinking and processing. Okay. So that term dementia, a lot of people interchange it with Alzheimer's or other Alzheimer's, Lewy body, senile dementia. Those are all forms of dementia. Dementia just means sick, brain sick, just means sick. Well, it's not the same thing. So no. So if I said sick, I could mean stomach sick, head sick, cold symptoms sick. Right. Dementia just means brain sick. There's something going on with the brain that's not right. Now, there's different types of dementia. There's multi-infarct dementia, which means the brain isn't processing correctly because of a lot of strokes. It could be Alzheimer's dementia, which is the one we're most familiar with, the one we hear about quite a bit. There's senile dementia, which just means getting older. The brain is naturally not cognitively processing the same way that it used to. But the term dementia, we just have to understand, is a very generalized term that just means the brain is not functioning the way it used to. There's different types of dementia. Good? Makes sense? All right. So then I want to explain to you just a little bit about what happens as we age with our brain. And this isn't a disease process. This is a normal sign of aging. So the best way for me to explain this is let's talk about a factory. If I went and toured a factory because I wanted it to produce something for me, and I toured a factory that's brand new, state of the art, everything works perfectly, the items that factory produces are going to be the best possible quality items, right? Everything's going to be consistent. It's going to operate at peak efficiency. Everything's going to come out working because it's brand new. Now, if I tour a factory that's 85 years old, that's obsolete technology, right? They're still having gears and springs and, it's very old technology. But even worse, that technology, even though it's old, has suffered the ravages of time. So it still works on springs and gears, but the gears are some of the teeth are missing and the springs are all rusted and not working well, and the conveyor might work today and might not work tomorrow. So the product that that factory produces is not going to be as viable. It's going to be hit and miss. It may be completely offline today, and the memory or the products that it makes aren't going to be as good quality. They're not going to stick around as long. Does that make sense? So if we understand that our brain is a factory, a memory making factory, when that brain makes memories, when it's young and brand new, those memories are going to stick around for a very long time because the machinery that made those memories was good quality when the memory was made. Does that make sense? Yeah. But fast forward 85 years, that factory that's supposed to make memories may not be working today at all. Or it may make a memory, but the memory isn't really good quality. It doesn't stick around very long. This is why we can have somebody who remembers the shoes they wore to a piano recital when they were 12, but has no idea that they just had lunch.
Or they don't know what they had for lunch.
Right, right. Because the memory factory that had to make that lunch memory is old and not working well today.
So like the long memory and short memory.
Right. So long-term memory often is intact. We can remember things from a while ago. Short-term memory tends to be a little bit more affected. Okay. Does that make sense? This happens with older individuals a lot. They'll walk into a room and they'll go, "Why am I here? I don't remember what I came in here for. I know I came in here for something." But just walking that, that short distance, that short-term memory didn't stick. Does that make sense? So when we're working with dementia patients, we have to have a lot of patience. We expect our patients, our expectation is our patients have the same cognitive level that we do. If they had the same cognitive level that we do, where would they be? At home. We wouldn't be taking care of them. So just by virtue of them needing assistance, we have to understand that they're not going to be at the same cognitive level that we are or the same physical level that we are. Now, when we understand that, that helps us develop that tolerance and that patience that we're going to need to work with these individuals. If they ask, "What time is lunch?" and you say 11:30, and 10 minutes later they say, "What time is lunch?" and you say 11:30, and 10 minutes later they're like, "What time is lunch?" You might get a little frustrated. "I've already told you twice, lunch is at 11:30. Well, what you're telling them isn't setting. It's not being locked in. So from their perspective, they've never asked you that question before. So answer it as often as they need you to answer it until it sticks or until lunchtime comes.
Okay, so as a dementia patient, what do I do if they're grabbing me like this?
Okay, dementia patients with specifically, it depends on the type of dementia patient, but specifically, let's talk about Alzheimer's, because Alzheimer's also affects the language processing. So when we have patients, and we talked a little bit about this last class, when we have patients that don't understand, good morning, don't understand what we're doing with them, we're rushing in, we're acting like they should understand why we're there and what we're doing. If they don't, they're probably going to react very physically by grabbing or pinching or hitting or kicking. And a lot of that comes from the place that they don't understand what you're doing with them.
So what do I do about it?
So work on your communication and your approach. So approach a little slower, have a seat, talk to them about the birds outside or a painting on the wall, or connect with them in some way so that it's not always task oriented. That can be very upsetting to patients, that, you know, the only time they see you is you come in and you put your hands on them. That can be right, that can be interpreted as a hostile act. So work on your approach and your communication attempts with them. Okay. So usually with dementia, aggression is a sign of inability to understand why you're there. Okay. They don't understand the role that you're playing, and they interpret that as a threat. And that's where that aggression comes from. You would react the same way. If some stranger, if you walked out that door and some stranger you didn't know came up and started to grab you and pull you somewhere, how would you react? Right. You would react negatively. You would hit, you would pinch, you would bite, you would scream. You would try everything you could do to ensure your own safety. Well, that is the mindset that our dementia patients are coming from, especially if we are projecting the wrong attitude, where we get frustrated with them and they can sense that. We rush because we've got too much to do. They can sense that. So our approach with dementia patients has a whole lot to do with their response. You also have to look at your nonverbal cues. How are you approaching them physically? So if I'm going to approach a dementia patient, I do not walk straight toward them. That can be threatening. I walk a little bit from the side. I look at my facial expression. Am I scowling? Is my face kind of closed off, or am I open and smiling and making eye contact before I approach them, so they know that I'm coming specifically to them? So there's a big difference between me approaching something like this. Hi, Miss Mary, how are you today? Do you see that I'm quite a distance away? I'm making eye contact. I'm friendly, but I also did this. Okay, this minimizes my body outline. So I'm not threatening in that. How are you today? Isn't it a beautiful day? Did you see the birds outside? I'm connecting on something that has nothing at all to do with the skill that we're going to do. That is completely different from, come on, we got to go get a shower. Okay, do you understand the difference between one? I'm approaching directly. I'm very matter of fact. I'm opening my body, projecting to be bigger. I'm not giving them any indication that I'm there to be friendly. Those two things, she's going to respond completely differently to. And you could actually see it in her face. I mean, she didn't know she was going to play along with this today, but you could actually see it in her face. The first one, she kind of dropped her hand and smiled at me. The second one, her hand went over her face. That was an unconscious protective measure. Do you guys understand that?
Not everybody can work with dementia.
Not everybody should work with dementia patients.
I work in memory care.
Mm-hmm.
I love it. But you have to be very patient, and there's a lot of people that are really mean with them.
Yes.
And they should.
No.
Sometimes I'm like, but there's nothing that you can do. I as a worker can't do anything with other aides.
That's where management should be involved.
Oh, yeah.
Management should be watching how the staff is interacting with patients and providing remediation and training where needed. So that, because before this lecture, you guys didn't understand any of that either, right? So that's where training comes in. So 10 minutes of training can actually make your entire workforce much more effective at taking care of dementia patients. It's just a matter of understanding that their mindset is going to be a little bit different than ours, and it's our job to accommodate them, not their job to accommodate us. We get that confused sometimes. Especially, and I'm not real sure why, but American culture especially really kind of reinforces this. that we expect everybody to have the same level of ability that we do, and we aren't willing to accommodate other levels of ability or even to see where they're coming from.
There are a lot of people that are nonverbal and they cry.
Yes.
You don't know why are they crying? They're like, why are you crying? Sometimes it's because they're hungry or they're in pain and they cannot. They don't even.
They can't articulate it. They can't
No,
verbalize
they
it.
don't know how to show you what's going on. And they cry all the
Well,
time.
and I'm going to take that a step further. Okay. It's not even so much that they can't show you what's going on. They may not understand themselves. They may not be able to interpret that feeling themselves. So, how can I articulate to you what I'm feeling if I'm not even sure what that feeling is? So, let's talk a little bit about Alzheimer's specifically. So, we just talked about dementia, the overall processing decline in the brain, and that's just because of age. Okay. Now let's talk about dementia or Alzheimer's form of dementia itself. Now, Alzheimer's, we have the whole aging process going on because that doesn't ever change, but we have something a little bit different going on as well. Now, you have to understand that memories that you make are not linear. We don't package up a memory into a nice, neat bundle, put a bow on it, and put it into long-term storage. That's not how memories work. Memories are a spider web, a collection of sights and sounds and smells and feelings. So when you want to recreate a memory, you don't go to a storage unit, pull out a box, unpack it, and there's your memory. Your brain actually has to recreate it with this sight, this sound, this smell, this feeling, and it pulls it all together and rebuilds that memory. So memories are not, they're not as accurate as we think they are. Okay, that's number one. Memories are not as accurate as you think they are. But memories are built from these different components. Does that make sense? Okay. Now, those components can be shared among memories. So right now, everybody in this room gets cold, right? You get cold because I'm standing up and I need it cool for me. So you guys are all sitting there, you get cold. So cold is now a feature of a memory for this class. So when you get cold 40 years from now, that cold is going to share with this class, the memory from this class. You also are all wearing the black shirts, okay? So if you combine cold and a black shirt, that might actually pull up a memory from this class. But the black shirts, this isn't the only time you're ever going to wear a black shirt. This isn't the only time you're ever going to be cold. This isn't the only time you're ever going to find yourself in a classroom. So those memories that you make in that new situation might mirror some memories that you had in an old situation. Does that make sense? So there's a correlation there. Okay. So we have to understand that these memories are made like spider webs, sights and sounds and smells and feelings, and your mind just puts them all together and rebuilds a memory. What happens with dementia is that the cords that hold that sight or that smell or that feeling to that memory get severed. They actually get torn, gummed up. So your brain might have an impression that I kind of remember something here, but I can't grasp it. There's something there, but I can't hold on to it. Does that make sense? Okay. So you can't reconstruct these memories. And if you can, it's probably memories that were made way earlier in your life, not much recent because of that whole dementia thing. Does that make sense? Everybody with me? Okay. So when we have Alzheimer's and we can't reconstruct these memories because we can't reach those pieces, the memories we have, the ones we are able to construct, are incomplete. This doesn't just affect People, and you'll hear this with Alzheimer's a lot. Mom doesn't remember me. And it's very upsetting to patients' families that how can mom forget me? And it's not that mom forgot you. You're still there in her brain. She just can't access it. The road is washed away. She can't access it. It's still there. She might access a memory of you earlier in your life. And that's why she calls your daughter her daughter, because that's the memory of you that she can access. Make sense? Okay. So this can be very, very frustrating for people specifically. But from an Alzheimer's dementia patient, this doesn't really affect them too much because they aren't aware that they don't remember because those memories aren't available to them. So it's not as upsetting to them. What is upsetting to them as we get into Alzheimer's, as Alzheimer's progresses, is we don't just lose people, places, and things. We lose the ability to recognize our own body signals. So right now, you guys sitting there know when you're thirsty and you take a drink. You know when you're hungry and you get something to eat. You know when you have to go to the bathroom and you take care of that. What if you weren't able to recognize those cues anymore? And that's what happens with Alzheimer's as it progresses. We lose people, we lose places, we lose things, we lose memories or components of memories. But over time, we also start to lose ourselves. We lose our personalities. We lose, think about what makes a personality, right? We lose the ability to recognize thirst. Well, if you're not recognizing that you're thirsty, that means you're not going to drink, which means that we have a high likelihood of developing dehydration. So when we're working with Alzheimer's patients, one of the things that CNAs need to do is remind our patients to drink a lot, way more than you think. So like every time you pass Mary in the hallway, you should be handing her a cup of water. Hey, Mary, take a drink. Hey, Mary, try this. I made it for you. Hey, Mary, this water today is really good. Can you try it and tell me? You want to find different and unique ways of getting your patient to take care of their personal needs that they're not even aware of. Same thing with hunger. If we aren't aware of what hunger is, we're probably not going to be very interested in eating. If we can smell food, but that has no bearing on us, we don't remember what that smell means to us anymore, right? We might absolutely love lasagna, and yet as we develop Alzheimer's and we smell lasagna, it doesn't trigger anything. It's kind of like smelling soap. Who cares? So when we have patients with Alzheimer's, they may only eat a bite or two and then get up and start wandering because it doesn't have that same importance to us. Now let's think about smell, which is also a sense that can be affected with Alzheimer's. If you can't smell anything, you probably aren't going to be interested in eating. So if your patient's sense of smell has been affected just because of those connections are no longer there, you can have a patient sit down and they'll look at their plate and wonder, what is this? What do I do with this? I don't know what to do with this because those memory connections have been lost. So Alzheimer's is not just, I don't remember my kids. It's the brain itself has lost its connection to you, what makes you, you. And that can be very frightening for patients because they have nothing to ground them. There's no sense of connection to anything, not to my own body. And that can be very, very triggering for patients. And a lot of patients with Alzheimer's will cry a lot because they don't have a connection to anything, not their own body, not memories, not you, not anybody they see around them, not the facility, nothing. They don't even recognize their own shoes. Nothing. Now, can you imagine how frightening that would be? it would be like just being dumped into an alien world all of a sudden with no understanding of why you're there or what your function is. And it can be very upsetting to Alzheimer's patients. So we get that, what we call emotionally labile, which means they can cry very easily or get angry very easily. Little things will set them off that you're like, why are they reacting to that? That makes no sense. Well, it does to them because they can't associate anything. So when we're working with Alzheimer's patients, we have to really understand them because they don't. We had one woman that I took care of here in the community, and she did not speak at all. She had lost all words, all words. She was completely nonverbal, and she was very emotionally volatile. She would smile at you, and the next minute she would try to punch you. She was all over the place, and it's because her brain just can't really latch on to anything. But she played the piano absolutely beautifully. So when she started to get kind of worked up, we would always take her to the piano and, okay, Miss Mary, come play me a song. Come play me a song. And she would sit down and it calmed her because it was the one thing that she could connect to.
Yeah, that's something weird about them. We're different about them. Is that once in a while they bring some live music and they put music from their 60s music, 50s music,
Yes.
70s, and they all know the songs.
Yes.
And they know the songs. It's like they sing.
Music activates a different part of the brain than any other medium. They've done a lot of, they've done a lot of studies with this. And music activates a different part of the brain. And it's a part of the brain that we don't normally use on an everyday basis if you're not listening to music. Okay, so that area of the brain just kind of gets put into storage, and it's not as affected by dementia. So think of it kind of like a little capsule in your brain, right? That has all the songs you've ever listened to. And that can be accessed even with dementia. And it's, again, these are memories that are generally made when the brain is younger. So they're better quality memories. And yes, music therapy is a big, big part of working with dementia patients. Also, when you're working with a dementia patient and they start to get worked up, sing to them. Sing to them or hum to them. Usually, in a lot of cases, old hymns work great. Old Rugged Cross, or When the Saints Go Marching In, or something like that, something that, from way back. A lot of times that will calm somebody. So sing to them or hum to them. I can't carry a tune to save my life. I am not a singer. I don't pretend to sing. But if I'm working with a dementia patient and they're getting really starting to rile up a little bit, I will sing, even though I know she's not going to judge me, right? It's not performance, it's connection. That's what we have to focus on, is connection. And we have to connect with them where they are. So a lot of times using old music will help with that. Music is a huge benefit to therapy. Huge. Yeah. All right, so let me go ahead and get your scores for chapters 5 and 6. Veronica?
I got 2
on 5 or 6?
5 and then 4 wrong on 6.
Okay, thank you. Deslin?
1 on 5 and none on 6.
Very good. Hannah? Bianca?
2 on 5 and 1 on 6.
Thank you. Bianca, do you have 1 through 5 or 1 through 4?
Yeah.
Sorry, I collect the scores before you come in. I'm sorry. I keep forgetting to go back.
1, I got
Okay.
2, I got 2. 3 is 4. 5 is 2.
Okay.
And then I did 2.
Yep. Got it.
Okay.
Do you have any questions on the ones that you've missed?
No, I just made simple mistakes.
Okay.
It's like, yeah.
If you find yourself struggling, just let me know. Sylvia?
I have in 6, I have 2.
Okay.
Can I ask you a question about 6, about this?
Sure.
I didn't find it, and I'm not sure, I don't know if it's a stupid question or not. Number 3 in number 6, it was if a patient begins to fall during transfer, the CNA should stop the fall. I didn't know how to do it. It's like stop
Okay.
the fall in any way possible. It's like
No, we don't stop the fall.
catch the
Bring them
patient
close.
before they hit the ground.
We don't catch.
What do we do? I was like,
Okay. So these are the answer options. So if a patient begins to fall during a transfer, the CNA should stop the fall any way possible.
uh-huh.
That will cause injury to you or them. We don't try to stop the fall. The B is catch the patient before they hit the ground. Again, that will cause injury to you or them. We don't try to catch anybody. C is step away from the patient to give them more room. That just lets them fall. I mean, that we can't do that. Yeah, we can't do that. D is bring the patient's body close and lower them to the floor. So this doesn't stop the fall, but it helps control the fall. So when we're working with patients, okay, if I'm transferring a patient, let's say I'm taking this patient from here to the wheelchair, okay, and I'm in the right body mechanics, which we haven't gone over yet, but I have the right body mechanics, and I lift the patient up and turn them to put them in the wheelchair. If their legs go out from under them, I'm not just going to drop them. I'm not going to try to catch them because that's going to put a lot of stress on my back and can blow out my back. What I'm going to do is bring them closer to me. So do you see how this leg goes out and my body comes back? What I'm doing is just shifting their weight closer to me, and I'm going to use me as a crutch to help lower them to the floor. Okay, so we're not stopping the fall. It's still a fall, but it's a controlled fall.
They shouldn't have any injury.
It's meant to help reduce injury, not eliminate, reduce. Yeah, you don't want to try to catch somebody because you are not going to be able, if somebody is falling and you try to catch them, you're not paying attention to your body mechanics. Okay? And we don't want you injured. We also don't want them injured. So I'm not going to go, hey, good luck. Now, this is one of the most misunderstood parts of being a CNA. And it's because we came out with something a couple years ago called the right to fall. Now, the right to fall does not mean good luck. It doesn't mean I'm going to stand there and watch somebody fall. What it means is that we're not going to restrict somebody's movement. So if they're in bed and they want to get up out of the bed, they're an adult. They have the right to get up out of the bed. I'm not going to come into your house at 2 o'clock in the morning when you want to get up to go to the bathroom and tell you, no, you can't get up. You're an adult. If you want to get up and go to the bathroom at 2 a.m., you're going to get up and go to the bathroom at 2 a.m. and nobody's going to tell you to get back into bed. Make sense? Okay. And yet we do this with adults all the time. We tell them, don't get out of that bed. You use that call light to call me when you need me. Okay. And they do. Their patients are great at that. They'll hit that call light and they'll wait. And they'll wait. And they'll wait because you didn't come. And they'll keep waiting. But at some point, this need is going to get much, much more urgent. And they're going to get up out of bed and they're going to walk to the bathroom. And you're going to come in and you're going to yell at them. I told you don't get out of that bed unless I'm in here to help you because you're going to fall. That is not a patient problem. That is a you problem. They did what they were supposed to do. They hit the call light. You did not come. That is a you problem. Why you didn't come, that is irrelevant, has no impact on this. You might have been busy with the patient. There might have been a code going on. That's irrelevant. This patient needed you. You weren't there. What are they going to do? They're going to take care of their own needs. You have no right to lecture that patient. None at all. Make sense? But we do. We lecture them all the time. So that's what this right to fall means, is the patient has the right to do with their body whatever they want to do, which means if they want to get up out of the chair and wander, they have the right to get up out of the chair and wander. If they want to get out of the bed to go to the bathroom, they have the right to get out of the bed and go to the bathroom. Whether they're weak or strong, they have the right. Now, the way I want you to think about this is if this patient were at home by themselves, would they be able to do whatever it is that they want to do? So the only thing that has changed is their location. That's it. That is all that has changed here, is their location. We don't have the right to impinge on their freedoms. Make sense? So we know that our patients are going to be up wandering sometimes when they're too weak to get up and wander. Their body may not be on the same page as their brain. So we have to know what to do in that situation. We don't want to catch them. We don't want to just step back and say, yeah, that's your consequence. We want to try to control the fall whenever possible. But the best thing that you can do, and this is a test question, the best thing you can do to prevent patient falls is to answer call lights promptly. Answer call lights promptly. Because if you don't answer that call light, that patient will get up. They will. No one is going to wet themselves in bed to be convenient for you. Does that make sense?
Yeah, and we'll be upset because they were the best.
Right. Right. One of my biggest pet peeves with staff members, especially staff members that have been in healthcare for a while, is I will see people at the nurses station talking about their weekend, their Mother's Day, their this, their that, and there's call lights going off in the hallway. And if I see that, whether I'm a staff member there or not, if I'm there visiting, I will remind them, you have call lights. Those call lights may be an emergency. This conversation needs to wait. And I don't make a lot of friends. I'm not there to make friends. I'm there to make sure that the patients are receiving the care that they are paying for. And those very same staff members, those very same people, when they're a patient, they will kick up all kinds of a fuss. If you aren't willing to provide the care that you expect, don't expect the care that others provide. Make sense? Okay. So when you're out there working, please remember that answering call lights promptly is a very important, high priority task. Very important. Probably one of the most important. I'll give you an example of this. This really irritates me when I see it online. People will, on Instagram, work does not belong on your social media, ever, ever. Nothing about your work belongs on social media, ever. Not your role. You are not being paid to post Instagram stories that make you look great at work. And I will see people posting videos hiding call lights, taking the call lights away from the patient and saying something like they're abusing the call light. There is no such thing as abusing the call light. That call light is there for the patient to call for help. You don't get to decide that they're using it too much. If they're using it too much, that means that you aren't taking care of their needs while they're in there. That's what that means. But they will hide the call lights. They will put them in places that the patient cannot reach. and they post it on Instagram. And this just irritates me to no end. But let me tell you a story that happened right here in this community. Call lights can be, for the most part, routine things. I need a cup of water. I need a blanket. I need to go to the bathroom. My remote fell on the floor. Very routine things. When you do that for a long time, when you answer those call lights and they're very routine, you stop paying attention to the fact that they could be urgent, and you delay. You delay. Now, the problem with that is those call lights can also be used for emergencies. So we had a situation here probably about 10 years ago. It was in one of our skilled nursing facilities, and it was nighttime. And after like 10 p.m., 10 p.m., they locked the doors at the facilities. And at this particular night, there was only one nurse on duty for the whole facility. They had several CNAs, but one nurse. And the nurse is at the nurse's station. She hears banging on the front doors. I mean, just banging. And she goes down the hallway to see who's banging on the door. And there are lights everywhere. Emergency lights. There's ambulances and fire trucks and cops and all kinds of stuff in the parking lot. And she opens the door. She's like, what's going on? They said, you have an emergency here. She said, no, I don't. I'm the only nurse here. I didn't call. I'm the one that would have to call for an emergency. They said, nope, you have an emergency here, and pushed her out of the way and went into the facility. And they went into a room, and the call light was going off in the room, above the room. And there was blood everywhere. There was a patient in that room who had esophageal varices, which is varicose veins in the esophagus, our food tube. When you chew food, it goes down the esophagus into the stomach. You learned about that in chapter 4, right? So these are varicose veins in that esophagus. So if they eat anything crunchy or sharp, it can cut these veins open. Well, when this blood, right, because we cut a vein, so blood goes down into the stomach. Stomach doesn't like blood. It ejects it, and it ejects it forcefully, and we get projectile vomiting that is bloody. And this patient can't talk at the moment because we have all of this going on. It's a horrible scene. So the patient hit the call light. Nobody came. The roommate was woken up by this patient's, what's going on. And the patient hits the call light. Nobody comes. The roommate hits call light. The roommate then starts screaming for help, 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 help. Nobody responded. Nobody responded. So what did the roommate do? Well, what do you do when you need help and nobody's helping you? 911. And that's what happened. That's how the nurse found out that she had an emergency at the center, is because the roommate used the call light, called for help. Nobody came. So they did the next best thing, called 911. Patient was transported to the hospital. The nurse got fired. So did every one of those CNAs. I think they should have been brought up on criminal charges. When a call light goes off, it is not up to you to determine whether you feel like going and answering it. When a call light goes off, it means that somebody in that room needs help, and that is your job, is to answer that call light. If you aren't doing your job, why are they paying a bill? That is the one thing that separates your facility from them being home. That is the one thing, is that call light. Because at home, they have no way to call for help. In a facility, that call light is what they're paying for. They're not paying for the food and the bed and the bathing. They're paying for the security of knowing that when they need help, help is available. And yet CNAs disregard call lights all the time because they think, well, I'll get to it when it's convenient for me. That's not what we should be doing. And several of the questions on your state exam are going to cover that exact topic.
Did the patient survive?
I don't know if that patient survived or not. I don't know. Don't know.
I think that if that person didn't survive, she should be, like criminal charges.
That's what I'm saying. I think that there should have been some repercussions there. Yeah. Call lights are way more important than you think. So when I see things on Instagram that people are hiding call lights, it really sets me off. Because what if that person falls in the next 5 minutes and they can't call for help?
Or a varicose vein.
There's a million things that could happen to them. They're not healthy. That's why they're there.
I saw when I got the job as a med tech.
Mhm.
Now I'm a med tech. I was checking on TikTok how they pass meds because I wanted to know exactly how they do the job. So I saw a nurse. She was a new nurse and she was passing meds, but she didn't hide the name, so we could see the name of the patient, and he passed out and all that. So she was passing the med and she made a mistake. She made a mistake on the video and she said, "Oh, I made a mistake," and it was a big deal. She got they took off, I don't know how to say it. Oh my god! But she was a new nurse and they took off her nurse certificate.
Yeah.
Because she put it because of the HIPAA and because
Right.
of putting it in TikTok and also making a mistake because she was wasting her time
Right.
her life doing her job.
Right.
It was a few months ago.
Yeah. I know what you're talking about.
You
I'm
see that?
familiar with it. Yeah.
Oh, okay.
Yeah.
There's been a few
Yeah.
recently online with
Yes.
similar situations, people violating HIPAA for the sake of live streaming themselves at work.
Yeah.
That was when I
Yeah.
got
Social media has no place in your work environment. You want to TikTok from home? That's fine. You want to TikTok from Disney World? Go for it. Do not TikTok or Instagram or anything else from a facility. Those people are not there for your, yeah,
Well, I love TikTok, but only to watch.
yeah, yeah. Oh, I've seen some recently where CNAs are twerking on residents.
Ew.
There was a surgeon who recently got fired for doing that as well.
Yeah.
That person was under.
Yep. Yeah. I mean,
Ew.
we need to restore common values and respect and dignity back to healthcare. You do not have to be the main character in every single story. We're bad about that. Sylvia, do you have scores for chapters 4 and 5? Chapters 4 and 5.
Chapter 4 and 5.
Yes.
Okay, let's see. 4, I have number 5. I didn't know 1,
Okay.
and number 5 is okay.
Very good. Very good. Chelsea, Nevaeh, Cynthia.
Chapter 5, I missed 4.
Okay.
Chapter 6, I missed 4.
Okay. Do you have any questions on what you missed?
No.
Okay. All right. Okay. So class is half over. If you've not registered for the test yet, you need to.
I did the practice days at the back of the book before
Okay.
I registered for the test, just to make sure how much I know. And I got like 90%, so I think I did very well. But there was one question, 41, that said a CNA enters the hallway and notices a visitor lying on the floor, not moving. There's no one else in the hallway. What should the CNA do? And then the answer was check for pulse and breathing. If not, start CPR.
Correct.
But we don't know CPR.
You don't have to have CPR for the class. You don't need it for the test, but you will need it to work in healthcare. You don't have to demonstrate CPR skills for the test, but you do have to know CPR for the written test. And yes, anybody that you see that doesn't have a pulse or isn't breathing, we have to intervene. Okay, whether it's a visitor or a staff member or a patient. Doesn't matter. If they need help, we're liable, we're required to help. And I'll give you a great example of this. This happened in Florida as well, I believe. Pretty sure this happened in Florida. And I'm this is several years ago, so I don't know if I've got the sexes right, but I believe it was the husband in the hospital. And the wife was coming he was a patient in the hospital. She was coming to visit him. And she's walking to the hospital, from the parking lot. And somewhere either in the parking lot or in the lobby, but somewhere before she got upstairs to him, she went down. And this is what everybody saw. She goes down. Now she's at a hospital and everybody's just standing there looking at her. Nobody jumped in to help. Nobody went to the ER to get help. They just watched. They just looked at each other and looked at her. These were employees of the hospital. And because they didn't know, what do I do? Should I start CPR? I don't know. What's my scope of practice? I don't know. So they did nothing. Can you imagine dying in a hospital where you've got help right there? Like the worst place.
That's the scariest thing.
The worst place to have a medical emergency is when you're a patient at a hospital. Because they'll walk right by that call light and not look in. In this case, it was the worst place to be when you're having a medical emergency as a visitor in a hospital because people just did not do anything. So yeah, this becomes very real very quickly when we start putting faces to it. Okay. Now, as far as the practice test goes, I usually don't tell students about that until we get to the last class because I'm not done with you yet. But the practice test in the book on page 192, I believe it is, if you miss 5 or fewer on that practice test, you're ready for the state exam. If you miss more than 5, then you're not quite there yet. And that's where the framework that I just made, that practice test framework, will help you understand that. So that is actually what we call a safety question. That's an S question, safety. So anything that is a sudden change that puts our patient at risk. Safety requires action. Not go tell the nurse, not ask somebody to do something. Safety requires action from you. Safety requires action. So if your patient is in jeopardy in the question, you know that your answer requires action. Never, ever leave a patient in distress alone. Never. So if we have a patient that's having a seizure, do we leave them? No, we send somebody else to go get a nurse. We stay with them and keep them safe. If we have a patient who is in a room with a fire, do we leave them to go hit the fire alarm? No, we take the patient out of the room. Patients and fires can never be in the same place. Take them out of the room. Get them to safety. Safety requires action. Then you can go tell the nurse after the patient is safe. But safety requires action. If your patient is choking, do you offer them water?
No.
Safety requires action, which means we need to perform abdominal thrusts. We need to dislodge whatever it is that's blocking their airway. Make sense? Okay. Safety, if your patient is in immediate distress, always requires action. Now, you should be able to very quickly, when you look at that question, if you see anything that puts our patient at risk, you should automatically know, okay, I got to find the action. Where is it? What answer puts me in the game? Good? Make sense? Those questions become very easy on the test. Very easy. Because the other three answers, one of them is going to be leave to go get the nurse. That will, no, you never leave a patient alone. So that's not the right answer. One question will have you doing something independent, like check their blood sugar. That's not your role, right? One answer will have you performing an action that will help with that situation. And then the last answer will usually be something like ask another CNA to do something. We don't delegate. Remember, CNAs only have two doors. We either follow the care plan or notify the nurse, right? Those are the only two things we can do. We follow the care plan or notify the nurse. Is delegation anywhere in there? No. So if an answer says ask another CNA to, or rely on physical therapy to, we don't delegate. That's not our role. So you can automatically get rid of that answer. You start to see how using these rules can help you with a written test really easily. If you know that the question says you are assigned to, then whatever you're assigned to do, you have to do. You find the answer that does that, right? That takes care of a whole bunch of questions on the test. If you know that safety requires action, you know how to answer those questions. Make sense? I haven't talked to you about communication yet. There's a rule for communication as well. Communication is, and this will be the next game show that we have coming up, not tomorrow, but a week from tomorrow, will be on communication. Those answers are the easiest ones ever. It'll say your patient says, your patient is crying, your patient is whatever. It gives you a scenario with the patient in some sort of distress, okay? And then a communication will always say, how should the CNA respond? Or the CNA should, right? So we're looking for a response here. What should you say? What should you say? That's a communication question. The answer, read the room, READ, read the room. Respect, empathy, acknowledge, and discretion. If the answer is not respectful, if it doesn't show empathy, if it doesn't acknowledge what the patient is going through, and it doesn't employ discretion, it is not the right answer. Read the room. It's all you have to remember for communication. Read the room. READ, respect, empathy, acknowledge, discretion. And that'll tell you the right answer for communication every time. Doesn't matter what the patient says, doesn't matter what the patient does. Your response is always respectful, empathetic, acknowledges the patient's position, and employs discretion. Always. So there's another 25% of your questions. Apply that one rule, you will always get them right. Always. Respect, empathy, respect, empathy, acknowledge, and discretion. Remember that HIPAA? Respect, empathy, acknowledge, and discretion.
Okay.
If your patient has dementia or is confused, if it says that in the question, if they have dementia or they're confused, the answer when they get upset is to redirect or reorient. Redirect or reorient. So if they're confused, redirect them. Come over here and work on this puzzle with me. If the patient is trying to get on a bus, clearly they're not getting on a bus, right? Instead of arguing with them, no, you're not getting on a bus. That's just going to make them upset. Instead of playing along, oh, the bus will come in a little while. Let's get your hat on. Let's get your glove. We're not going to play along either. That reinforces the delusion. That's not the right answer. So if your patient is confused, we redirect. It's not time for that. Why don't you come over here and tell me about where you're going? Okay, we're going to take them somewhere, get them involved in something. We're going to redirect so they don't fixate on that. Let me tell you something about fixation. We don't think about this. We don't, this isn't like in our reality, okay? But this is very real to our patients. When you have nothing to do, now let's pick on an older woman. She's in her 80s, okay? She spent her whole life taking care of the house and the kids and her husband. And now she's in her 80s. She's in a facility. She has nothing to do. Nobody needs her. Husband is dead. Kids are all gone. She has nothing to do. And her whole life was built around taking care of everyone else. Now, you would think, because you're trying to get there, oh, thank God, right? Nobody needs anything from me. This is a vacation. It is not a vacation for her, because in her mind, somebody needs me. Somebody needs me to do something. I am needed somewhere, not here. And she will fixate on that because she feels like a part of her life is missing, and it is. So a lot of times with these individuals, we will have them folding washcloths, matching socks, doing something industrious and productive to keep them from fixating on the fact that nobody seems to need me. If you don't do that, your patient will start fixating on the smallest things. And my grandmother did this. So my grandma lived at my mom's house. She had a little apartment at my mom's house. She had congestive heart failure and the blood didn't get to her brain very well. So she was confused at times, hallucinated occasionally, but she didn't have anything to do. She had nothing to focus on. TV will only hold your attention for so long. And she had a home health aide that would come in and take care of a few things, help her with her shower, and make her bed. I told you that I learned at 3 years old how to make hospital corners, right? The person that taught me to do that was my grandmother. She was very fastidious. Everything had to be just so. And I learned how to make a perfect hospital corner at 3. There was no sloppy anything with my grandmother. Well, this home health aide would come in and make the bed, and it was sloppy. My grandmother would sit in her recliner where she could see the end of the bed, and she would look at that hospital corner for hours and work herself up. Now, she couldn't get up and fix it, but it got under her skin. So by the time my mom would walk in the room with dinner or something, my grandmother was biting her head off. Not because my mom did anything wrong, but because she had fixated on the fact that this hospital corner was not done correctly and it ruined her whole day. Because she had nothing else to focus on. So we taught her how to play solitaire on the computer. That helped. Because now she's not focusing on these little details that she has no control over. When you focus on something that you have no control over relentlessly, all it does is reinforce the fact that you have no control. Let's go back to that 2-year-old. Remember that 2-year-old? When they don't have any control, they throw a tantrum. That's all that was happening here. If you understand this from your patient's point of view, you can put things in place to help them feel like they're a productive member of the community. Folding washcloths. You can distract them with playing a piano, doing a puzzle, an activity of some sort, so they're not fixating on these little details that are going to ruin their whole day. And by extension, they're going to ruin yours. Make sense? People don't think about these things when they're taking care of dementia patients. Dementia is 10% physical care, 90% emotional care. Read the room. Okay. All right. So class is half over, guys. Game show will be a week from tomorrow. We're going to be going over communication questions. So I'm going to speed through these. We've been through them before. Okay. As a CNA, we follow the care plan, the whole care plan, and nothing but the care plan. While we do that, we make observations and we report all observations to the nurse. Every skill starts with an opening. Every opening starts with a knock. We're going to greet our patient. We're going to address them by name, introduce ourselves by name and title, and tell them why we're there. We're going to get permission, close the curtain, wash our hands, and then get our supplies. One of the supplies that we may need, cardinal rule, don't touch the patient until your hands are clean. One of the supplies we may need are gloves. We don't wear gloves for everything. When you wear gloves for everything, you stop paying attention to what you're touching with those gloves. So we're going to wear gloves if we're touching body fluids or personal skin or non-intact skin. Outside of that, you don't need gloves. You're going to wash your hands before, you're going to wash your hands after. You don't need gloves for routine skin-to-skin contact, okay? If you do wear gloves, the first thing they should touch is the patient. You have to know how to remove your gloves correctly and be careful about what you're touching in the environment while you're wearing soiled gloves. You don't want to unnecessarily contaminate the environment. If we're going to use supplies, we have to have a clean place to put them. And that's what a barrier does. It provides a clean place to put our clean supplies. And we only touch supplies with clean hands. So during the test, do not walk in the room and get your supplies before you do your opening. You will see people do that. Don't do that. Go ahead.
So, we get there, we wash our hands, we get the supplies, and after that, we put the gloves on, right?
So
To
we're,
know when to use your glove.
yeah, we're going to read our care plan first. Always read your care plan first. Then you're going to do your opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to whatever. Is that okay? Close curtain, wash hands. Then we get a barrier and put it on the table. Then we get our supplies and put that on the barrier. I'm not ready for gloves yet. I am not ready for gloves yet because the first thing my gloves should touch is the patient. What if I have to go get water to bathe the patient? I don't want gloves on for that. What if I have to put a privacy blanket on the patient? I don't want gloves on for that. What if I have to sit the patient up to a sitting position? I don't want gloves on for that.
Okay, so I have to do everything around, and before touching the patient, I'll go wash my hands again.
No, you don't have to wash your hands again. You do have to put your gloves on though. Okay. Yep. So you have to think about why you're wearing those gloves. Okay. You've touched all that. You've put a blanket on the patient. You put the head of the bed. You know, you've done all these things, right? Right? Okay. Does that patient, so let's put you in the bed for a second. Okay. Does that patient want you with these dirty hands, or not horribly dirty, but do you want those hands up around the patient's face? So that's why we're wearing gloves, to protect the patient. That's right. That's right. So we're going to touch all those things, and that's fine because we're going to cover our hands with gloves before we get right down to it. Make sense? Okay. Remember, those gloves are not being worn for the reason you think they are, because things do get through those gloves. They're not a magic suit of armor. They're not there to protect you as much as they are the patient. Okay, good, good. All right, don't let supplies touch your uniform, right? We don't hold anything up against our uniform, and get the barrier first before you get your supplies. One of the supplies you may need is a privacy blanket. Now, privacy blankets are used both for warmth and privacy. Patient has to be covered with something. So anytime the patient is uncovered or undressed, we're going to use a privacy blanket. We put it on top of the sheet and then pull the sheet down underneath so the patient's always covered. I don't take the sheet away and then put the privacy blanket on. Good? Okay. Don't snap or shake the blanket when you put it on. Just lay it out. And it's always removed after you remove your gloves if you wore gloves. Because remember, we wore gloves for body fluids. We don't want to put those body fluids on the sheet. Good? So if you wear gloves, take those gloves off before you take the privacy blanket off. We also learned about linen rules. Now, linen rules are mostly repeats. The linens can't touch your uniform. We already know that. Must have clean hands to get your linens. We already know that. Don't snap or shake the linens. We already know that. Clean rolls toward me, dirty rolls away. This is how we put anything under the patient. We're going to see this again today. No, I'm sorry. We're going to see this again Wednesday. Don't let anything touch the floor. The only thing that should touch the floor are shoes. And unused items must be discarded. Patients should always be in the middle of the bed. Don't rely on side rails to keep your patient safe. Being in the middle of the bed keeps them safe. So in order to have a patient in the middle of the bed, we're going to scoot them toward us before we roll them away from us. We remain behind the patients behind. Always roll them away from you. Washing rules. We wash everything the same way. We do have a washing skill today. Basins are no soap zones. We don't put soap in the basin. That keeps that water clean for rinsing. We're going to use a paper towel to turn the faucet on. We're going to check the water with the inside of our wrist. It should feel warm, not hot, not cold, just warm. We're also going to ask our patient to check the water temperature. We're going to wash, then rinse, then dry. And if the water gets cold or soapy in that time frame, we're going to change that water. Try not to get your surface wet, whether it's the table for most skills, the floor for foot care, the bed for partial bed bath, which we're going to get to today. Try to keep your surface dry with a towel or chucks or something. And then if we put lotion on, we warm it up first and then we wipe off the excess. Now, if we're working with basins, we have to know how to clean them after use. And this is just as simple as rinse it, dry it, and store it for the test. But we're going to go just one step further. We're going to dispose of our fluid wherever it normally goes, rinse the basin and dispose the rinse water wherever we put the fluid. We're going to set the basin down in the sink so we're not touching it. We're going to pick it up with a paper towel. We're going to dry the inside with a paper towel, throw it away. We'll dry the outside with a paper towel, throw it away, and then one more for the supplies in the drawer. Okay. We also learned the closing. At the end of every skill, the patient must be in a clean and safe environment. So look around. Is everything clean? Does the patient look good? Are they in the middle of the bed? That's a big thing you should be looking for. But make sure the sheets are adjusted properly. There's no trash on the floor. Everything looks good. And make sure the bed is in the low position. We're going to ask about comfort. They need to hear that word. Are you comfortable? And we're going to address preferences by offering them a magazine or something. We're going to give them their call light. Make sure they're covered. And open the privacy curtain. I like to thank my patient while I'm doing all this. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? These little things that I'm telling you go a long way in establishing a relationship between us. If I am just like very businesslike and matter of fact, and you need anything else before I go, the patient's probably not going to tell me what they need. And that's actually going to make them use the call light a little bit more for two reasons. Number one, I didn't address their needs. But number two, more importantly, they don't feel bad about interrupting me. They just don't. They're looking for some entertainment, some feedback, some connection. So they'll hit that call light over and over and over and over again. This is one of the things that I used to do in one of the facilities I worked at is I tracked how many times patients use call lights. That tells me a story. Patients that use the call lights more are having a need that's not being met. That tells me which CNAs I need to start looking at and which nurses I need to start looking at, because patients that are in pain are going to hit that call light. That tells me that my nurses may not be taking care of the pain management of that patient. They may be diverting. They may be taking that pain medication themselves. I need to address that, right? But I also look at, how many times are they asking for blankets and water and bathrooms and things like that? That tells me that the CNAs are not taking care of the patients while they're in the room. So the patient's constantly having to use those call lights. And then you have some patients that will use the call light just to interrupt you on purpose. They're looking for that attention. Well, that's a need that's not being met. So I've got to work on a strategy to address that need. Ideally, your patient should only be using that call light for a true emergency. If you're in the room and you're taking care of the patients while you're in the room and you're doing it in a way that makes them agreeable to talk to you, right, that opens up that communication, you'll take care of everything with this patient. They'll tell you what they need, and then they'll be off of the call light. Make sense? So if you're just doing this really quickly, do you need anything while I'm here? Are you comfortable? Here's your call light. I'm going to open the curtain and go wash my hands. If you do that, your patient is not being cared for. You might be checking those boxes, but you're not caring for that patient. So slow down. Thank you so much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Do you want a blanket or anything? How about a magazine before I go? I'm going to make sure that they're taken care of. And then here's a call light. If you need anything, just let me know. And I'm going to open the curtain. Now, what I've done is two things. I bought myself some time because she's got everything situated. But number two, she likes me now. She's going to feel bad about hitting that call light for something that's not important because she likes me. You want patients off the call light? Connect with them. Make it personal. Good? All right, so we're going to go, okay, let me go back here. Where are we? There we go. So page 80 in our book is range of motion, hip, knee, and ankle. Now, we have learned 2 range of motion so far. You guys remember those? Range of motion shoulder and range of motion elbow and wrist. The things that you need to know about range of motion is it doesn't matter what body part you're going to do them on. Just follow the care plan. There's 3 exercises you can do: up, down, side to side, and around. You have to know, according to the care plan, what body part, which of those exercises, and how many repetitions, and just follow that. Up, down is the same whether it's here, up, down, or here, up, down, or here, up, down. Up, down is up, down. Side to side, right? Side to side. Doesn't matter what body part you're working on. Side to side is always side to side. Rotation is around, around, around. Okay, doesn't matter what body part, rotation is around. So all we're going to do is figure out, according to our care plan, what body parts, which of those exercises they want us to do, and how many times do we need to do them. So range of motion are the easiest skills there are. Page 81 has our step-by-step instructions. No supplies for this one. Care plan's at the top of the page, but let's look at this care plan. Provide the following range of motion exercise to the resident's right hip, knee, and ankle. Flexion extension. We know that's an up-down motion. So we're going to do range of motion to the hip, knee, and ankle, up, down. It tells us to provide 3 repetitions. So how many? 3. So we're going to go up, down on the hip, knee, and ankle 3 times. Now, for the most part, this skill is just a little bit different than others because we're actually going to do the hip and the knee together. Okay, together. One exercise for both joints. And I'm going to show you why in a minute. We know everything we need to know to do this already. Oops. All right. So remember that the care plan is going to tell us what body part. It's going to tell us what exercises and the number of repetitions. We're going to support the extremity near the joints, and we're going to lift from below with a flat palm. We're going to move slowly and smoothly all the way to start. Flexion extension is up, down, which is what this care plan is telling us to do. We're not doing abduction, adduction. We're not doing rotation. We are going to monitor for pain. But hip and knee is going to be done at the same time. So when I bend the hip and bend the knee, you can see they're both bent at the same time. Now, this is actually important. It's not a shortcut for us. It actually has to do with patient comfort. And that's because of this. As we age, this nerve that runs down the back of your legs all the way to your heel, this nerve, this is called the sciatic nerve. It branches off of your spinal column, right? So we get down to the lower back. It branches into two, one down each leg. We have this nerve going all the way down. Remember that as we age, everything is affected, even our nerves. So our nerves are like rubber bands. When you have a rubber band and you stretch it and it's new, it stretches and it bounces back, no problem. That rubber band, if you found a rubber band from 1912 in great grandma's house, is that rubber band still going to stretch? No, it's brittle. It doesn't stretch. In fact, it's probably going to break because it's brittle. Make sense? Okay, that's what happens here. As we age, the nerves get less flexible. They become more brittle. So when we elevate the leg without bending that knee, when we pull the leg up, that stretches this nerve really tight. This can cause something called sciatica, which is pain down the leg. Starts in the lower back, but it spreads all the way down, and it's very uncomfortable, very painful. Your patient's not going to be able to get comfortable laying down, sitting, standing. They just can't get away from this pain, and it can last months or years. We don't do this. Do not do this. The way to prevent that kind of pain is, let me go back here, is if we bend the knee at the same time, okay? We bend the knee. When we bend the hip, it gives some of flexibility to that nerve. It doesn't pull it straight. Good? Make sense? All right. So for the hip and knee, patients laying in bed, we're going to bend the knee up to the chest and back down to the bed like they're walking up steps. But this is what it would look like if I were laying down. This is what it would look like. You have the knee bent and the hip bent at the same time. Okay? Now, the other body part that we're working on is the ankle. So we're going to bend the foot forward like they're stepping on a gas pedal and back to stretch kind of along that lower leg. So forward and back to the head, forward and back to the head. But I don't want the heel to scrape against the sheets as we do that. Because remember, as we age, our skin gets thinner and drier, and we can actually cause a skin tear this way. So what I want to do is lift that leg off the bed just a little bit, not much, just a little bit, so that when I bend that foot forward and back, we're not scraping that heel. Good? Okay. We don't do abduction, adduction for this particular skill for the test because it's not on our care plan. We don't do rotation on this particular skill for the test because it's not on our care plan. We are going to ask about pain. Good? So now we know all these steps. Let's use them to check off our checklist. We're going to follow the care plan and only exercise the joints indicated. We're going to do our opening. Knock, knock, knock. Hi, Ms. Jones. My name is Patty. I'm your CNA today. I'm here to do range of motion. Is that okay? Close curtain, wash hands. No supplies for this one. We're going to decide if we need gloves. If my patient is fully clothed and holding on to all of their own body fluids, I do not need gloves for this. And that's how it's going to be for the state exam. Your patient is fully clothed and holding on to their body fluids. If I am working on this lady and she's incontinent and she's not wearing anything under that gown, I probably need a set of gloves. I'm going to be a little too close to her lady parts, right? Personal skin. There's urine, which is a body fluid.
You just move to do the exercise. You just move one side of the sheet, do the exercise.
Or you can use a privacy blanket. Either way is fine. Just make sure they're covered.
So
Okay.
we only take the part of the body that we're gonna be
Right,
exercising. Okay.
right. We're going to do our skill specific steps and then we'll finish up with the closing. Remember that this care plan is only for this patient. This one has a different care plan. So does this one. So does this one. Different care plans for different people. We're going to follow the care plan.
I'm sorry, I keep doing. I just want to make sure that I got everything. Flexion extension is like bending.
Up, down, right.
Flexion.
Up, down. If you want to remember this, USA again. Flexion, extension, up, down. Abduction, adduction, side to side. Rotation, around. So if you look at it, flexion, extension, up, down, U. Abduction, side to side, S. Rotation, around, A. USA again. Up, down, side, side, around. Up, down, side, side, around. Good? Jake's going to show you this video. It takes like 2 minutes. Super quick.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Wonderful. I need to do some exercises on your right hip, knee, and ankle. Is that okay?
Yes.
Okay. I'm going to close your curtain. Let me go wash my hands, and I'll be right back. Okay, after washing my hands, we're ready to get started. The first exercise I'm going to do is bring your knee up to your chest and back down to the bed. I'll do all the work. All you have to do is let me know if there's any pain or discomfort. We're going to provide 2 points of support, one under the knee and one under the heel. And we're going to lift up and all the way back to the bed. Feel okay?
Yes.
Any pain?
No.
We're going to do it again. Up and all the way back. And one more. Up and all the way back. Feel okay?
Yes.
Okay, now I'm going to work on the ankle. I'm going to lift your leg off the bed just a little bit, and then I'm going to bend your foot forward and back. You should feel a little stretch. Please let me know if there's any pain.
Okay.
So I'm going to lift under the ankle. We're going to bend the foot forward and then back. Feel okay?
Yes.
We're going to go forward and back. Feel okay?
Yes.
One more, forward and back. Good?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Are you comfortable?
Yes, ma'am.
Environment is clean. Bed is in the low position. Here's the call light. If you need anything at all, just press the red button and we'll be happy to come help. I'm going to open the curtain and go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. Okay, any questions on range of motion? That's the last range of motion, so we're done with those. Like I said, those are the easiest ones on the state exam. I would want that. All right, any questions? We're going to go ahead and take our break. And then when we get back, we have 3 skills to learn. 2 of them won't take us too terribly long. I do have something to explain with both of them. So there's a little bit of a lecture. The third one is the longest skill there is, and that's partial bed bath. You should hopefully, if all goes well, get about 20 to 30 minutes of practice time at the end of class today. On Wednesday, you'll have about 45 minutes of practice time at the end of class. Monday, you'll have about an hour and 15 minutes at the end of class. And then on the last class, you'll have about 2.5 hours of practice time built in. Okay. It does go by fast. Yes. It goes fast. Yeah. Can you imagine people that try to shove all of this into 2 days? Yeah, there are weekend preps, and they try to shove all of this information and they don't get to all of it. So basically, you just go over the skills and that's it. But think about all that we've learned in between the skills that's very important to us. Yeah, I really think that this class could be 1 week longer, but all right, let's go ahead and take our break. Jacob, you're going to have Okay. We're back. All right, any questions on range of motion? All right, the next skill that we're going to go over is denture care. You guys already know half of this skill because denture care is mouth care with an extra step. So you guys already know half of this skill already. If you look at the overview page on page 96, you'll see all of the principles on the side. They're all spelled out for us here. We're going to learn these. I have a video for this. Down here is your test-specific information. Somebody with your level of experience, which is none, should be able to complete this in 13 minutes or less. You will be doing this on a live testing student. That person will be positioned in a chair at the beginning of the skill. Now, a lot of you are like, wait a minute, how can I do denture care on a live student? Let me explain. If you go to page 97, you can see the care plan at the top of the page. We're going to go through that in detail in just a moment. Step-by-step instructions, and then supplies are at the bottom. I will tell you that this skill seems to be the hardest skill for students to learn. Denture care. Because there's two very well-defined parts to it. And it involves a glove change. And students get a little confused as to when to change gloves, okay? So this does seem to be one of the harder skills for students. Here's our care plan. It says a resident with dentures is sitting at an overbed table with their dentures in a denture cup. So we start the skill with another testing student sitting in a chair and their dentures are already out and in a cup. That's important because CNAs do not take dentures out. CNAs do not put dentures in. Patients have to be able to do that on their own. If the patient cannot do that, well, that's okay. They just don't wear their dentures and we puree their food. But when CNAs try to take dentures out, dentures are held in with denture paste, gummy, stringy. To take dentures off of a lower jaw, you have to put a lot of downward pressure on the jaw. You risk dislocating their jaw. So CNAs don't take dentures out. We also don't put them in because when you put dentures into somebody's mouth, their mouth is going to bite down to seat those dentures. They won't pay attention to whether your fingers are in the way. So CNAs don't take them out. We don't put them in. So dentures are either in the patient's mouth or in a cup. Good. So our care plan says they're sitting in a chair at the overbed table and their dentures are already in a denture cup. We are going to brush the teeth, the dentures with toothpaste, and perform mouth care. And then it says the denture is stored in a denture cup after cleaning. And that's why we can do this on another testing student because we're not putting dentures in. We're not taking dentures out. The dentures stay in the cup. They start in a cup. We clean them. They end in the cup. And then we clean the mouth they came out of. Okay? It says resident is not able to provide own mouth or denture care. All right. So we know all of these. We know to follow the care plan. We know to do the opening. We know how to wear gloves. We know to use a barrier. We know not to hold linens against our uniform. Don't put them on the floor. We know how to clean our basin and we know how to do our closing. Nothing here to learn other than our skill-specific steps. And that's what we're going to focus on for this lecture. So CNAs are going to clean both the dentures and the mouth those dentures came out of. This is a two-part skill. You can't just clean the dentures and leave the mouth. It's got food and denture paste and enzymes and all kinds of stuff in there. So we have to clean the mouth as well. And it doesn't matter. If you want to do the mouth first, you can. If you want to do the dentures first, you can. But if you do the mouth first, it adds an extra step. because then you have to clean the emesis basin that they spit into before we can use it for denture care, and then you have to clean it again at the end. So it's actually quicker to clean the dentures and then clean the mouth. Okay, good. Now, there are a few different types of dentures, and I want to go over this really quickly. We see them here. We have full plates of dentures. That look like this. This is a full plate. All of the teeth have been replaced. Okay. This is an upper. I know because it has a palate that fits against the roof of the mouth. A lower has a cutout for the tongue. Okay. So a full plate is going to replace all of the teeth. A partial, which is what this is, a partial will replace some of the teeth, but it also has cutouts for the patient's natural teeth. They usually have some sort of a ring to help clamp it, around an existing tooth. So you may have full plates, you may have partials. They're both cleaned the same way. You may have either. And you also may have a piece of a denture called a bridge. This just replaces 2 or 3 teeth. It has a patient tooth on each side that it clips onto. Now, technology has come a long way, especially with dentures. We now have implants that actually click into place rather than using rings. Not all of your patients are going to have dentures like this. Some will have implants. We go by the care plan for how to clean each type of appliance that our patient is using.
So it's kind of like a retainer.
Similar. Yeah, similar. Bridges now, if we're replacing a few teeth, you'll see them permanently implanted. So they don't come out. Some are on posts that click into place. Every denture care has come a long way. So they now over in, I think it was Japan, I saw this weekend. They are working on technology that regrows teeth. Yeah. So at some point in the not too distant future, we may be able to replace decayed or diseased teeth with a graft of some sort. So that will be interesting to see what happens in the future with this. But for right now, our care plan tells us the resident's denture needs to be brushed with toothpaste. So keep that in mind. We're going to talk about that in a minute. And it says the resident needs mouth care. So we're going to clean the dentures and the mouth those dentures came out of. Now, you've heard me talk about our practice kits. And this is one class where the practice kits really kind of become important. So our practice kits, you can see them up there. They contain everything that you need to be able to practice for the state exam. And one of the things that's in that practice kit are dentures. They're fake. You can't really use them. They're just resin. But it has a channel, just like dentures do. And you can use this to practice denture care, cleaning the dentures. They're actually included in the practice kit along with a denture cup. Okay? So we have those available to you. There are 2 ways to clean dentures. You can clean them with a toothbrush and toothpaste, which is what our care plan said, or you can clean them with fizzy denture tablets. So there's 2 ways of cleaning dentures. How do we know which one to use for our patient? The care plan, and our care plan here tells us to use toothpaste. So this is the method we're going to use. Some patients don't want us to use that because toothpaste is abrasive. It actually causes little micro cracks to form, and those micro cracks can hold bacteria, and it reduces the lifespan of the dentures. So a lot of your patients are going to be like, no, don't do this. Do this. Because these denture tablets are specially designed to break down that denture paste and release those particles. And then we just use a soft brush to get off any of the bigger particles and rinse. So it depends on how the dentures were made. Patients pay for their dentures, and the people that make the dentures tell the patient, use this or use this because there's different materials. Good? Okay, so we always go by the care plan. We're going to use a special brush for dentures. This is called a denture brush. Looks like a toothbrush, but it's double-sided. This side, the small side, is designed specifically to be able to fit in the groove. It's smaller and it's tapered specifically to clean the groove of the dentures. This part looks like a toothbrush, and that's the part we use on the teeth part of the dentures. Okay. We also use it on the palate. So you want to, when you're using toothpaste, you want to use a denture brush. We're going to put toothpaste on both sides after wetting it. And we want to make sure that we're covering all surfaces here. Good? Okay. So we know how to clean the dentures. When we're getting ready to clean the dentures, we have to do some prep work. So we always wet a brush before we put toothpaste on it. We learned that with mouth care. So we're going to wet the brush. We're going to put some toothpaste on it, but we're not over at the sink yet. We're not ready to brush yet. So we have to have a place to put it just for it to hang out for a minute until we're ready. And that's what we're going to use the basin for. So we get our denture brush wet. We put some toothpaste on both sides, and then we put it in our basin. We're going to take this basin over to the sink because we do not want a toothbrush to be placed on the side of the sink. You want it to be in a basin. This sink is not clean. You don't want to put something that's going to go on something that goes in the patient's mouth on a dirty sink. Good? Good. Okay. Dentures have to be in your hand. Do not ever set them in the sink. They're either in the cup, in your hand, or in the patient's mouth, but that's it. They do not get wrapped in napkins. They do not get laid on a surface. They don't get put in the sink. They don't certainly never lay them on the side of the sink. Okay, they have to be protected. Dentures are expensive, $5,000 to $6,000. If these dentures break, the facility has to reimburse the patient. So we want to be really, really, really careful with our dentures. Please make sure you have gloves on when you handle dentures. There's body fluids there. We're going to put a washcloth in the bottom of that sink. Now, this is a safety step because if those dentures, which we're going to put toothpaste on, they're going to get slippery. If those dentures slip out of your hands and they fall and hit the bottom of the sink, they're likely to break. So we put a washcloth in the bottom of the sink to provide a softer surface in case we accidentally drop those dentures. Even better, if you can get that washcloth over the drain. Because if you put the washcloth over the drain, it helps the water pool up in the sink. So if the dentures fall, they hit the water and then slowly sink down. They don't actually hit a hard surface. Okay? Washcloth on the bottom of the sink, essential step. So we don't want the toothbrush or the denture brush to touch the side of the sink. We don't want the dentures in the sink. Basically, nothing should touch the sink other than the basin. Good? We're going to use cold water for this, not hot, cold water, because hot makes proteins stickier and harder to remove. Cold water. We're going to turn on the faucet, but our hands are clean. We've washed our hands. We got our supplies. We did our prep work, but our hands are mainly clean. We're about to touch those dentures, right? So do we want to touch that faucet with those gloves that are going to touch the dentures? So what could we use? A paper towel. Now, it doesn't matter whether you turn the water on before or after you put your gloves on. Does not matter because you're going to use a paper towel. So gloves first. Okay. Water first. Okay. Just use a paper towel no matter what. Like I said, this skill gives students kind of a hard time because the order, they're like, well, what comes first? What comes next? So I'm trying to give you rules to follow. And if it's not a rule, it doesn't matter. So turn the water on first. Fine. Put your gloves on first. Fine. Just make sure there's a washcloth in the sink. All right. Use cold water, not hot. We're going to brush whatever the patient's got, right? So we've got some dentures there. We're going to brush them. Top, the bottom, the groove, the teeth, the palate, the whole thing should be covered in toothpaste when we're done. Easy? To go to checkpoint. Keep the dentures over the sink. Keep them in your hand. Don't set them down in the sink. Once the dentures are clean and rinsed, then we're going to rinse out that denture cup, fill it up with cool, clean water, and now our dentures can go into the denture cup. Dentures must be stored in water. Otherwise, they become very brittle and they break. Okay? So we clean the dentures, we rinse the denture cup, we fill it with cool, clean water, and we put our dentures in our denture cup. Good? So this skill is not nearly as hard as people think it is. We get our denture brush ready, wet it, put some toothpaste on it, put it in the basin, take it to the sink. Put our washcloth in the bottom, and we're going to turn the cold water on with a paper towel. Put your gloves on before or after, doesn't matter. Once you've got the water on and your gloves on, get your dentures, rinse them, brush all surfaces. Rinse them, clean the cup out, get some water in it, put the dentures back in the cup. That's it. It's not hard. But now the skill's only half done. Okay, good, good. Now, that cup, because we dumped it and we rinsed it and we filled it, that cup is wet. Do I want to put a wet cup on a wooden surface? No, we need something underneath that cup to capture the water. So we're going to use a paper towel under the cup just to protect our surfaces from getting ruined. Okay. And then at the end of denture care, when we're done with the dentures, we've got them in our cup. We've got our coaster paper towel under the cup. We're just going to put them back on the bedside table for the patient to use anytime they want to. We don't put them back in their mouth. We just put them in an easily accessible place for the patient. Okay. Now we're going to go back over to the sink because we're not quite done here. We've got to go back to the sink. We still have a washcloth in the bottom of that sink. So let's take care of that. Do we throw it on the floor? What's the only thing that can go on the floor? Shoes. So we're going to wring it out. And we're going to put it directly in the hamper. We also have to get that basin and denture brush that's still hanging out. Okay. And we're going to bring it over to the table. We're going to take the denture brush out of the basin because the patient's going to spit in that basin in just a minute. And I don't want to touch that brush with clean gloves. Take the brush out, put it on the tabletop, the barrier. Good. Now we're done with the dentures and we're ready to do the mouth. Do I want to put those gloves that I just used for all of that stuff in that patient's mouth? So we're going to take our gloves off because we're done with dentures and we're going to get ready to do mouth care and then put our mouth care gloves on. We do not because it's the patient's cooties. Okay. So we are done with dentures. We took those gloves off. We're not going to put the new ones on quite yet because we still have some prep work to do. Okay. Remember our rule? First thing gloves should touch is the patient. So we're going to dunk our brush in water and put some toothpaste on it, put a towel over the patient's chest, and then put our second set of gloves on before we start mouth care. Good. I know there's a lot of steps here. A lot of steps. We're not going to use a toothbrush here because toothbrushes, remember a patient's got denture paste all through here. Denture paste is gummy and stringy and it holds on to food particles. So if we use a brush, it's going to get all gummed up pretty quickly. So we use something different. We use a toothette or an oral swab. This is a soft, spongy surface, but most importantly, it has 4 specific sides to it. So I can use this to swipe away the denture paste on the top, turn it a quarter turn, swipe away the denture paste on the bottom, turn it a quarter turn, swipe away the denture paste up here, turn it a quarter turn, and the 4th one will swipe the denture paste away down here. So I can use this, each surface, on a different quadrant of the mouth. And then you just throw this away. If you were using a brush, you would have to go to the sink and rinse that brush out over and over and over again, and it would take more time than you have. Good? So I'm going to pass these around. So the 2 types of dentures, the denture brush and the toothette, so you can see what they're like. I'm going to start over here, and then we'll end over here.
I'm sure you probably said this earlier. And then we have mouth care.
We already went through mouth care last week.
No, not mouth care, denture care. Like when we go to do the
Yes. Denture care is on a test and care plan set.
When we clean the patient's mouth, so it's not actually like how you brush your teeth normally because they don't have teeth. With that brush, do you just take the what is it called, the glue or whatever out? So you don't actually like brush their mouth, you just take the glue out.
Right. So when we're brushing teeth, we're trying to remove any food particles. Removing it from gums is way easier than removing it from teeth. So just get the denture paste off of and the food particles off the gums.
So like it doesn't have to be for 2 minutes.
No,
or
no.
The same with the dentures, we just
Right.
have to clean them.
Just clean them.
Okay.
No time requirement there. Great question.
And if the patient has teeth,
Okay, so that's a good question, because if they have a partial, they may have some teeth in their mouth. Again, you're going to go by your care plan. If I have a patient with more teeth than not, then we're probably going to use a brush because there's going to be less paste. Right? Make sense?
Yeah.
So we would go by the care plan. If you ever have a question, who do you ask?
nurse.
The nurse. Yeah, you want me to use a brush or a toothette? And they'll tell you. We actually use touthettes, that soft spongy thing. We use that to brush teeth with sometimes, especially if your patient has like a fungal infection in the mouth. A brush can hurt. If the patient has just had oral surgery, right? We don't want to brush in there. So the oral swab might work better. So there are some situations where even with teeth, we're going to use an oral swab. You would go by the care plan for that patient. Okay. So we have to do all of this before we put our gloves on. We're going to get our swab wet. We're going to put some toothpaste on it. We're going to lay it in that basin just to hold it for a minute. And we're going to put a towel on our patient. And we're going to do all of that before we put our gloves on, just like we did with mouth care. Now, our patient's already sitting up for this skill. They're sitting in a chair at the bedside. So they're already sitting up. Remember mouth care, they were laying in bed. We had to put the head of the bed up. We don't have to do that for this skill. They're already sitting. And then you're just going to brush what they got. Top, bottom, front, back, tongue, brush what they got. Let them rinse as often as they need to. And if they rinse, they have to be able to spit as often as they need to. Once you're done with this, please make sure that your patient's mouth and face is dry. Remember, this step gets missed a lot. And then we're going to dispose of our linens properly. So everything goes into the hamper, not on the floor. I keep stressing that because this is a checkpoint that is being missed a lot. A lot of people testing are taking linens that are used and throwing them directly on the floor. Remember that that's a contamination that you're spreading on that floor that people are going to walk through and take throughout the facility and home with them. Nothing goes on the floor but shoes. All right, so now we know all of the steps. So let's put them together and get some checkpoints. We're going to follow our care plan. Care plan tells us exactly what to do. We're going to do our opening. We're going to wear gloves, both for dentures and for mouth care. So we actually have 3 checkpoints on gloves. We're going to use a barrier on the table. We're going to use linen rules. Remember, we don't hold anything against our uniform and we don't throw them on the floor. We're going to clean our basin at the end like we clean all basins. Dump it, rinse it, dry it, store it. We're going to use these steps. Now, look how much we have that is skill specific here. There are a lot of steps you're being graded on for denture care, and this is why it's often one of the harder skills for students. Okay, and then we're going to do our closing, and we don't get a whole lot of checkpoints for the closing on this one. Most of our checkpoints is coming from the actual skill itself, which is opposite of what we see with most skills. Most skills, the opening and the closing make up about half. So this one is a little bit different in that we still have to do all of those steps, but we're not getting as many checkpoints for the closing as normal. Still have to do them all. Okay, good. So this care plan is only for this guy. She doesn't have dentures. We just do mouth care on her. She has implants. So we do mouth care on her because her dentures don't come out at all. This guy, we still do denture care on, but he uses the fizzy tablets. So this only applies to this guy. Remember, we never treat all of our patients exactly the same. Good? Questions? All right, we're going to go ahead and watch the video on this.
Hello.
Good afternoon, Mr. Jones. How are you?
I'm well. How are you?
Wonderful. My name is Patty. I'm your CNA today, and I would like to help take care of your dentures and perform mouth care. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. I'm going to take your dentures to the sink to clean them.
Okay.
I'll bring the denture cup to the sink on the paper towel. We're going to set it on the side of the sink and open it, placing the lid beside it, and then wash my hands. After washing my hands, I'll get my supplies. We're going to start with a barrier. This is going to provide a clean place to put our clean supplies. So we'll spread the barrier out on the table with the absorbent side facing up. And for this skill, I'll need a towel and a washcloth, being careful not to let the supplies touch my uniform. I'm just going to go gather the rest of your supplies. I need a toothette, a denture brush, and toothpaste, along with an emesis basin and a cup of water. We'll set these on the overbed table. And I need 2 sets of gloves. Okay, I'm going to get the denture brush ready. We're going to wet it and apply just a little bit of toothpaste on both sides. Set it in the emesis basin right now. I'm going to take the washcloth, a set of gloves, and the emesis basin holding the denture brush to the sink. Mr. Jones, I'll be right back. I'm ready to clean the dentures, so I'll set the prepared denture brush in the emesis basin on the side of the sink. I'm going to place the washcloth in the bottom of the sink over the drain and put my gloves on. I'll take a paper towel and turn cold water only on because we only wash dentures with cold water, and we're going to throw that paper towel away. Now I can clean the dentures. I'm going to take them out of the denture cup and rinse them off, making sure that I hold them over the sink at all times. I'll take the denture brush, and the small end of the denture brush is going to clean the groove part of the dentures. So we're going to clean that whole groove, all areas, and the palate. Then we'll turn the dentures over, being careful to hold them securely, and use the other side of the denture brush to clean the teeth part of the dentures. We want to make sure that we cover all surfaces. Making sure that we hold it securely. And then we can rinse the denture brush and put it back in the emesis basin for later use. We're going to rinse the dentures off, removing all of the toothpaste. We'll take the denture cup, dispose of the water, rinse it out, and fill it with cool, clean water, placing the dentures inside. Cover it with a lid. We can throw this away and get a clean paper towel to place underneath it. I can turn the faucet off, and we're going to go put this on the patient's bedside table. I'll place this denture cup on your bedside table over here for use later. Now I can remove the washcloth and place it in dirty linen. Now I'll bring the emesis basin holding the denture brush over to the overbed table and take the denture brush out and set it aside. Now I can remove my gloves. I'll throw these gloves away. Mr. Jones, I'd like to place this towel over your chest while I perform the mouth care portion of this skill. Is that okay?
Yes.
I'll get the toothette ready. We're going to get it wet. Put a little bit of toothpaste on it. And then hold it in the emesis basin while I put my gloves on. Okay, Mr. Jones, I'm going to brush all areas of your mouth, the top, the bottom, the front, the back. So I need you to open up wide for me, please. I'm going to start in the back, on the top, both sides, and then the bottom in the back, the front, and can you bring your teeth together? Thank you. Okay, thank you very much, and we'll rinse. Pour the rest of the water in there. And just make sure that your mouth is nice and dry. Okay, I'm going to place this in dirty linen, clean my basin, and then clean my work environment. I'll be right back. We'll take the basin to the sink and dispose of the contents into the sink. We'll then rinse the basin and set the basin down in the sink. We'll use a paper towel to pick it up, a paper towel to dry the inside, a paper towel to dry the outside, and then one more for the drawer. On the way to the drawer, we'll pick up the denture brush and the toothpaste, placing them in the emesis basin for storage. The supplies away, we'll use a paper towel to open the drawer. We're going to put the basin, toothpaste, and denture brush in the drawer, and then close it with the paper towels, and we can then throw the paper towels away. And now I'll dispose of all of my disposables, the cup, the wrapper, and the toothette, along with the barrier. These will go in trash. Now I can remove my gloves. We'll throw the gloves away. Thank you very much, Mr. Jones. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes.
Would you like a magazine before I go?
No, thank you.
Your environment is clean, your bed is in a low position, and you're safe. Let me give you your call light.
Okay.
Here's your call light. If you should need anything at all, just press that red button and we'll be happy to come back and help. I'm going to go open your curtain and wash my hands. After washing my hands, I'll review the care plan, make any corrections, and then tell the evaluator my skill is done. All right, any questions on denture care?
So you don't throw away the denture brush because it's not actually used on the patient for the paste, it's just used on
Right,
the,
right. Yep. So this is the practice kit I was telling you about. It has the dentures, it has the denture brush, it has denture cup. All of that is in the kit. It also has a gait belt, which we're going to use on the next skill. So I just want to show you that the practice kit has everything you need to practice outside of the classroom. Okay, so page 66. Is Ambulate with a gait belt. Ambulate is just a fancy word for walk. So we're going to walk our patient. Here are all of the steps down the side. They're all spelled out for us here, all the principles. We're going to learn the test specific or skill specific steps. Down here, you can see test information. Somebody with your level of experience should be able to do this skill in 5 minutes or less. Super quick skill. It's going to be done on a live testing student. So you might be a patient for this. The patient's going to start out in a chair. This is not a documentation skill. So if you look at page 67, we have our care plan at the top. We have step-by-step instructions. We have our supplies at the bottom. For this skill, your patient's already going to be in a chair with shoes on. So you don't have to put shoes on them. They'll already be wearing them. But you do have to verbally acknowledge that they're wearing shoes. Okay, so that they know you understand that's a step. So the only real supply for this skill is going to be our gait belt. This is one of my favorite skills. It's easy. We're walking a patient. But a lot of this has to do with safety and body mechanics, which is what we're going to talk about now. But we also have to understand something called energy conservation. And it's not something that you on your own would kind of think about. So I have to bring it to your attention. So here's our care plan for this skill. Ambulate the resident at least 10 steps, use a gait or transfer belt. Those are the same thing. It's just two names for the same item. Patient will be sitting at a chair at the side of the bed with shoes on. So we don't have to put their shoes on, but we do have to say something about it. And patient is able to walk, but needs assistance to stand. So in order to understand this, we already know all of our steps or all of our principles, but we do need to learn one more, and that's shoe rules. So we're going to concentrate on that before I show you this particular skill. Page 63 has some notes here. And I want to show you something. Oops. I want you guys to be able to see this. There we go. Okay. Jake, you might want to lower the camera a little bit. All right, so let me explain to you about energy conservation, because you guys are young. You won't understand this. Have you guys ever seen a 2-year-old? You ever seen a 2-year-old? 2-year-olds have tons of energy. I mean, way more energy than I have, for sure. In fact, if you look at a 2 or a 3-year-old, they will bounce up and down for no reason at all. They don't need a reason to bounce. They just have energy, right? When was the last time you bounced up and down for no reason? Probably when you were 2. Yeah. Because that's actually when we peak in energy. Now, we have to understand that there's an inverse relationship between energy and strength. The more strength we have, the less energy it takes to do something. The less strength we have, the more energy it takes to do something. And you've probably seen this without even being aware of it. Have you ever seen an older person try to get up out of a chair? It kind of looks like this. No. Right? How much energy did that take? Oh my gosh, so much energy, right? That rocking takes energy, that lift and then fall back down takes energy, that momentum to get it going again takes energy, and then the standing takes. That was a lot of energy that was expended at one time. A whole lot more than if I had simply stood up, right? I can stand up because I have strength, which means I require less energy. Make sense? All right, well, as we get older, our strength diminishes, which means that everything that you do and take for granted is actually going to cost the patient more energy to do the same thing. Now, you're not really going to think about that, right? You think get up out of a chair, right? You think this doesn't require much effort at all. But our patient isn't going to come at this with the same level of ability. So for them, that whole rocking back and forth is going to require more energy. Does that make sense? Well, the problem is that when we talk about energy, we talk about energy from down here. We don't think about energy from up here. So we're going to talk about this a little bit. Somewhere between 2 and 3 is when your energy levels peak. And it's downhill from there. We don't really recognize it. We don't really see it, but our energy levels do decrease. But I'm going to prove it to you. Just go out 10 years. Let's go out to 12 years old. 12 years old still has a ton of energy. I mean, they can play, they can rollerblade, they can play basketball, they can video game until the wee hours of the morning, still tons of energy. Put that 12-year-old in charge of that 2-year-old for one afternoon. Who wins? The 2-year-old. The 12-year-old would be like, Mom, can you make them take a nap? They're wearing me out. I'm done. I don't want to do this anymore. Your energy level has dropped just in that 10 years. Now let's go up to 22. 22-year-olds can shop till they drop and go out at night looking fabulous, right? But you do not have the energy level you had when you were 12. Let's go out to 42. 42-year-olds are shopping till they drop, but that's at 3, and we're not going out tonight. Go out to 62. 62, we're thinking about retirement because there's just not enough energy to do the whole full-time work thing, take care of the house and all the stuff that needs to be done. So we're thinking about retirement, cutting back, putting our feet up for 10 minutes before we make dinner because our energy levels have declined significantly. Now, what do you think they're going to be like at 82? Right? And that's, you know, who we're helping, guys. So we have to understand that we come to them with energy levels like this. Their energy levels do not match. They have significantly lower energy. Now, why do we care about this? Why do I have to have this conversation with you? Have you ever been with a 2-year-old and tried to explain to them why you don't have the energy they have? Do they ever get it? No. You can talk to your blue in the face. They're not going to get it because they've only experienced their own energy level. They think everybody has the energy they do. They know no different. Does that make sense? Okay. When you are working with this patient, okay, remember, you tried to explain to them that you didn't have their energy. They didn't get it. They try to explain to you that they don't have your energy. You aren't going to get it because you're not there yet. And you're going to say things like, oh, you can get a shower. I do all the work. All you got to do is sit there. No, it's not all they have to do. They have to get undressed. Even sitting takes energy, right? So they're going to tell you, oh, honey, I don't have the energy for that. And you down here are going to go, what do you mean you don't have the energy? I do all the work. What? And you're going to argue with them. Guys, when they say they don't have the energy, they mean they don't have the energy. And let me show you why. So if we know that we need energy to get through our day, right? We have to think about all the things in the day that take energy. So what kind of things do we do every day that takes energy? Well, you can figure it out by using this phrase. Have you ever been too tired to, whatever that is, it means it takes energy. Have you ever been too tired to walk? Have you ever been too tired to eat? Have you ever been too tired to talk? On Mondays and Wednesdays, when I'm done with class, I am too tired to talk. I have talked nonstop for 4 hours. I need a break. I need some quiet time in my life, right? I am now too tired to have a long conversation. Have you ever been too tired to, whatever's on the other side of that, takes energy. So showering, dressing, working, but even things that we don't think about take energy. Things like digestion takes energy. Breathing takes energy. Sitting up takes energy. So things that we don't even think about is going to take energy from our patients. So why this is important is, let me go back here, is if we only have this much energy to get through the day, this is it. We can't go to the energy store and buy more. This is all we have. And we have to do all of these things Can you see how we might run out of energy before we run out of day? Now, where this becomes a problem is that one of the last things that we do is eat. And that eating, remember I said that we burn calories to generate heat, right? So one of the last things that we do in the evening is eat. And we eat to keep up our body temperature, but also to provide energy for the next morning. So if we run out of energy before we get to dinner, and we go to dinner and we just don't have the energy to eat, and we eat a bite or two and we're like, I'm done, I can't eat anymore, I'm tired. And we go to bed, what do you think energy levels are going to be like tomorrow? And you're going to run out of energy even earlier. And this sets up a downward spiral. So this is why this skill becomes important. When we have somebody that has to rock that many times to get up out of the chair, we are going to loan them some of our strength so that they don't have to use as much of their energy. And this is called energy conservation. And it's very important among the elderly. And it's one of the main reasons that we're there to help them. We're there to give them some of our strength so they don't have to use as much of their energy. And this can actually help with their lifespan. Something this simple. Does that make sense? Let's think about how many times an older patient has to get up. Okay. They have to get up out of bed. They have to go to the bathroom. They sit down on the toilet. Then they have to get up off the toilet. Then they go to their bed and sit on the edge of the bed to get dressed. And then they have to get up from there. Then they go to the bathroom and they brush their teeth and comb their hair. And they're probably tired. So they're sitting on the toilet to do that. So they have to get up. Then they go to the dining room and sit down and eat. And then they have to get up. And then they go to the activity room and sit down and watch a show until they get tired. And then they have to get up and go to their bed to take a nap. They lay down and then they have to get up. And then they have to go to the bathroom. They sit down on the toilet and then they have to get up. And now we finally have gotten to lunchtime and they go sit down at lunch and then they have to get up. And that's all by lunchtime. If every single one of them involved that whole rocking, do you see how we can run out of energy really quickly? That's what this skill is all about. If we can help conserve some of their energy with all of those getting ups, then we might have enough energy to get us through the day. They might be more agreeable to taking a shower. Okay, make sense? All right, so I want to talk to you just a little bit about diabetes. This is a 5th grade version of diabetes. I've really watered this down, so those of you online, don't come at me. Diabetes is a very, very, very big topic. People go to school for years to become diabetic educators. I'm not doing that with you. I'm just explaining basics, okay? Every cell in your body, every single cell, doesn't matter what kind of cell it is, every cell needs glucose to run. Every cell. Now, sugar gets a bad rap in our society, right? Sugar is not bad. All of your cells need it. That's like saying gasoline is bad. All the cars need it, okay? It's not bad. It's bad in excess. Our diet is excessive. In America, we don't do anything halfway. We're excessive with everything, right? So that's where this goes wrong. It's not that sugar is bad. It's that sugar in excess has to be dealt with by the body. And we're going to explain that in a minute. But every cell requires sugar to run. When it runs low on sugar, it sends a notification to your brain. It says, hey, I'm hungry, I'm starving, feed me. Brain says, oh, we must need some sugar. And it triggers a craving. I'm hungry. I want some fries. I want a burger, because all carbs are sugar when they break down into the body. So your cells get hungry. They tell your brain, hey, we need some food. The brain says what we need is carbs, because carbs break down into sugar. Good? Make sense? So carbs, things like bread, rice, pasta, potatoes, flour, anything made with flour, sugar, anything made with sugar. Basically, we call it the rule of white. If it's white, it's probably sugar-based. When you eat something that is a carbohydrate, it's going to break down into sugar in the body. Now, that sugar goes into the bloodstream and it circulates and it circulates and it circulates and it circulates, and we need to get it into those cells. The problem is that sugar itself just can't enter the cell. It doesn't work that way. Sugar needs a key to get into the cells. Your body actually makes the key. It's called insulin. It's made by the pancreas in your body. So you eat carbs, they break down into sugar. The brain says, hey, pancreas, give us some insulin. Pancreas then produces the key, and the key opens the cell, and then the sugar can enter the cell. And now the sugar is fed and happy, and life is great. Good? Make sense? Okay. So this is our system. It is a factory in the body. So we eat sugar, we eat carbs, they break down into sugar, the sugar goes into the bloodstream, and then the factory kicks up, starts producing insulin. If we use this system too much, if we are constantly telling our pancreas, give me more insulin, 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 because our diet is nothing but sugar, then our pancreas starts to wear out and we develop type 2 diabetes later in life. And it's all because not of what we ate this week, but because we have constantly overused our pancreas. So this actually happens in childhood. And this is the American diet, okay? So we have a 5-year-old gets up super early in the morning, 5:30 in the morning. Mom's not ready for all of that. So mom gives the kid a Pop-Tart, sits him in front of the TV, and crashes on the couch. That Pop-Tart are carbs. Those carbs break down into sugar, goes into the bloodstream. Our pancreas has to produce insulin. Mom wakes up about 6:30 and gives the child some cereal, but the child isn't eating Raisin Bran. The child is eating Captain Crunch, Fruity Pebbles, Lucky Charms. Those are all carbs that break down into sugar that make the pancreas produce insulin. And then we have a mid-morning snack. Now, this is a good mom. She gives the child fruit for a mid-morning snack, but that fruit still breaks down into sugar in the body, which means that the pancreas has to produce insulin. And then we have lunch. We have chicken nuggets and mac and cheese, which are carbs that have to be broken down into sugar and make the pancreas produce insulin. Then we have an afternoon snack, probably some cookies or a little Debbie something. Those are carbs that break down into sugar and make us produce insulin. And then we have dinner, buttered spaghetti, which are carbs that break down into sugar that make our pancreas produce insulin. And then, of course, we always give children dessert before bed, which is sugar that makes our pancreas produce insulin. And we keep up this eating style throughout most of our lifetime. So by the time we hit 60, 70 years old, our pancreas is like, nope, done. You've used me up. There's nothing left. I have nothing to give you. And we wonder, how does this, I've been eating right. I've been eating salads for the last 3 years. But that's a Band-Aid compared to what we have, all the abuse we've put it through over our lifetime. Make sense? Good? All right. So be careful. Protect your pancreas. Don't overuse it. But if we do have diabetes, the problem here is not the sugar. The problem here is the insulin. Because we've overused our pancreas, we're not producing insulin. So our cells get hungry and they send a signal to our brain, I'm hungry. And the brain says, we need some carbs. So we eat the sugar, we eat the carbs, it breaks down into sugar. Brain tells pancreas, hey, give us some keys. And in a healthy person, the pancreas will produce that key, that insulin, which opens the door and it allows the sugar inside, cell is happy. In diabetes, what happens what happens is the cell is hungry. Brain says, I need carbs. Those carbs break down into sugar. They go into the bloodstream. Brain says, hey, pancreas, give me some insulin. And the pancreas says, no way, I'm done. I'm offline, not happening. So that sugar just accumulates. It can't get into the cell, but that cell is still starving. So it sends another signal to the brain. I'm dying here. You got to give me something to eat. So the brain says, craving. I need a chocolate bar. I need a cookie. I need a donut because my cell is dying. It's not helping anything because that sugar goes into the bloodstream and it still cannot get into the cell. This is how we get high blood sugar, and it triggers cravings. The cravings come because the cells can see the sugar, but it can't get to the sugar. Make sense? Good. Now, two things with this. Number one, your diabetic patients will crave sugar. They're craving sugar because their cells are starving. They're literally dying. Literally dying. So if the cells are dying and your diabetic patient is eating sugar, it's because their brain is trying to keep the cells alive. We know that's not going to happen. We know that's going to make the situation worse, but that diabetic patient is just responding to, I'm dying. Make sense? So don't yell at your diabetic patients. They know they shouldn't be eating that candy bar, but their cells are literally dying. They're doing what they can. So how can we help this person? Well, on the back side of the cells, there's a little tiny door. Not as big as this one. It doesn't work as well, but there is a little door. And that door is opened with protein, not with insulin, with protein. So if we have a diabetic patient that is craving sweets, we know this is happening. We know their blood sugar is high. Those sweets aren't going to help them, but they're reacting to something internal that's very real. So if we can get them, okay, I know you're eating. I know that you're craving, but if we can get them to eat some protein with it, that protein will open up the back door of the cell and allow some of this sugar to go into the cell. And that keeps the cells running, but it also helps reduce that craving. So if you've got a patient who is eating graham crackers, which is our carb, pair it with peanut butter, apple and cheese, a half a tuna fish sandwich. The bread is the carb, the tuna is the protein. So we want to pair a protein with carbs, and it helps divert some of the sugar that's in the bloodstream into the cell where it needs to be. Good? Okay. We're not really trying to reduce the blood sugar as much as we are trying to fuel the cells. Make sense? Good. Most of your diabetic patients will have a bag of M&Ms stuffed underneath their pillow. Yep. So let me explain to you what's happening inside the body and why this is dangerous. Sugar is a crystal. Do you see how sharp and jagged this is? Okay. So sugar is very similar to this. It is a crystal, has lots of jagged edges. Now, this crystal, when it's in the bloodstream, is circulating. We can't get rid of sugar. We only have two choices, two things that we can do with sugar. They either go into the cells, or if we have excess sugar in the blood that isn't getting into the cells, we put it in storage boxes and shove it in fat cells for later. We actually convert it to a storage form of glucose. So we either store it or we use it. We don't want it circulating. But when our storage units get full and there's no place to put this sugar, our blood sugar rises. We now have diabetes. And we have to think about what that sugar is doing on the inside of the arteries. Remember, it is sharp and jagged. Now, these sugar molecules, these crystals, okay, because we have gravity on planet Earth, These crystals are heavy. They're going to be pulled down to the lowest parts of the body. So what's the lowest part of my lower body? My feet. What's the lowest part of my upper body? Yeah, my hands. So diabetic patients are going to have the most effects in their feet and their hands. Hand care, foot care. That's why we do those two skills. Got it? It's all because of gravity. So let's talk about the sugar molecules. Okay, so we know they're going to be pulled down, but what does that really mean? Well, the sugar molecules coat the inside of the arteries. And when they coat the inside of the arteries, they stick, let me go back, they stick to the inside of the arteries. And because they're jagged, they catch everything that floats by. They catch cholesterol, which looks like pizza cheese. They shred cells, like red cells that carry oxygen, and white cells that help with your immunity. So diabetes is going to affect every system in your body because of how it affects the bloodstream, right? If we have so much sugar in the bloodstream, there's no room for everything else. And that sugar is going to coat everything and make it sticky and gooey and shred cells. When we're born, our blood vessels look like this. Those are beautiful blood vessels, wide open. I got lots of room for everything in there, right? But as we keep up with this diet, our vessels start to narrow a little bit. And if you look at the difference between these two, you can see this one is narrower, just a little bit, not much, but it's starting to thicken up a little bit. Now, over time, we're told, this is probably our 20s, we're told, hey, little bit of activity wouldn't hurt you. Few green salads would probably help, right? But we don't pay attention because we like our pizza. So we keep that up, and by the time we get into our 30s and 40s, our blood vessels look like this. Now, this has significantly reduced the blood flow. We aren't getting as much blood flow to our areas. We're getting tired or quicker. Now, if we don't pay attention to this and we don't fix this, then over time, our blood vessels turn into this. Yeah, so understand that anytime blood slows down or stops, it clots. Do you see how much buildup is in there? It has slowed down that blood, which means that this blood is going to clot. When it happens in the heart, we call that a heart attack. When it happens in the brain, we call that a stroke. Our patients are at risk of blood clots in the legs, heart attacks, and strokes with diabetes. Good. Yep.
She got a stroke, she got a heart attack.
Yep. And it's all because of the effects of this sugar inside the arteries, how it coats. But the sugar doesn't just coat the inside of the arteries, it also coats the nerves. And if you've ever lived up north during like a blizzard and you get ice on the lines, right, you end up with brownouts or even blackouts, like you lose power because power can't travel through that. The line is coated with ice. Well, this happens in the nerves of the body too. And again, we have gravity. So the legs and the hands. And when this sugar coats the nerves, it prevents signals from traveling back to the brain. So I could step on something sharp and my foot knows that object is there. My foot knows, hey, we've got a problem. But I can't get that message all the way up to my brain because the signal won't travel. This is why we do foot care, because your patient may have an injury to their foot that their brain does not know is there. That's why we look. Good? So with diabetics, it's very important that we pay attention to their feet and their hands because that's where most of our effects of diabetes is going to be. This interruption in signal has a name. It's called neuropathy. And it feels like a bunch of ants on your hands and legs. feels like pins and needles, like you sat on your legs too long and they went to sleep and they start to wake up. That's what neuropathy feels like all the time. Very painful. Good? So that's just a little bit about diabetes. So when we're going to walk a patient, we want to make sure that we're protecting their feet, because if they have, and most people have some sort of blood sugar problem in America, we don't want to walk them without, with just socks on, because if they step on something sharp, their brain may not ever know that that's there. We need to protect them. Slipper socks are not enough. If the patient refuses to wear shoes, or if the patients have no shoes, let the nurse know. Slipper socks are not enough. There's another problem with slipper socks, though, that most people don't think about. Have you ever been a patient at a hospital? If you've ever been a patient at a hospital, they give you a gown and those socks. And you got out of bed and you went to the bathroom and you did whatever it is you were going to do in the bathroom. You might have even walked downstairs or walked around the nurse's station when you were bored, and you got back into bed with those slipper socks on. What got into bed with you? All the pathogens you encountered. And if you had an incision anywhere on your body, do you know where those germs are going to get? Incisions are warm, dark, moist, the ideal breeding environment. This increases the likelihood of a surgical site infection. Do not walk patients without shoes. Good? Okay. When we put a gait belt on a patient to help stand them, right, because we're going to use our strength, don't grab them around the pants, the waist of the pants, and try to lift them that way. That gives them a wedgie. That hurts. Don't grab them by the back of the arms, because you're having to put so much pressure on the back of their arms that you can cause injury. So we want to put a gait belt around their waist. We're going to use that belt to help them stand. When you put a belt around the patient's waist, you want to check it with 4 fingers. You just want to be able to fit 4 fingers flat between the belt and the patient. Not like this, okay? 4 fingers. If that belt is too loose, when you go to lift the patient up, if that belt is loose, it's going to go under the breasts, under the arms, or they'll slip right out of it. It's got to be snug. Not so snug they can't breathe. But we need that belt to stay in place. So we check it with 4 fingers. Before we stand a patient, we have to make sure their feet are flat on the floor. Now, I have a problem with this. I've got short legs. If I sit with my hips all the way back against the back of the chair, my feet are not flat on the floor. But you wouldn't really know it unless you looked really close. So for me, I have to scoot forward so that my feet are flat on the floor. Make sure your patient's feet are flat on the floor before you stand them. Otherwise, if they're not, if they're on their tiptoes, when you lift their body, they're going to tip forward and they're likely to fall. Before we stand a patient, we're going to count to 3. 1, 2, 3, and then stand, and we're making them a partner in this. I'm not just going to throw a gait belt around somebody and then lift them and manhandle them and move them, because they're not participating then, and they're probably going to fight back. Communication counts. Once we get somebody standing, I want to ask them, hey, are you dizzy? I want to know here. I don't want to wait until I'm 10 steps away from the chair to figure this out. If I stand somebody and say, are you dizzy? And they say, yes, we're sitting down. We're done. We're not going anywhere. I'm going to go find a nurse, because that's a nurse problem. That is not a me problem. Right? So we stand them up, give them a second to acclimate, and then we ask, are you dizzy? If they say, no, I'm good, we're going to walk. Now for the test, we're going to walk 10 steps. That means 5 steps in one direction and 5 steps back. We're not walking far. You want to make sure there's nothing in your pathway before you walk. You never want to leave a patient to move something. So just take a look. Is everything clear? For the test, they'll actually give you a destination like walk to the table and back. So just look. Is everything clear? Can I make my way through there without a problem? If not, before you lift that patient, move whatever's in your way. stand them up, or put the gait belt on, check it with 4 fingers, count to 3, stand them up, and ask if they're dizzy. Once we return back to the chair, they have to know that chair is behind them before we ask them to sit, before we help them. So I want to back them up so their knees hit the back of that chair, and I'm going to ask them, can you feel the chair? And then I'm going to help them sit using the same body mechanics. Now let's talk about body mechanics. If you stand directly in front of somebody, knee to knee and toe to toe, if I'm standing directly in front of somebody and lifting them toward me, their whole body weight coming toward me is going to push me off balance. This is bad body mechanics. Don't do that. We used to teach people to do that. Don't do that. The best way to lift somebody is to stand at an oblique angle, a corner of a box. So one foot goes in front of their feet perpendicular across. The other foot goes beside them. So we're standing at the corner of that box. We're going to bend at the knees, not the waist. We bend at the knees like this, not like this. We bend at the knees. And then we put our hands around the back of the patient and hold that gait belt. Their hands, do you see how her hands are on my shoulders? Their hands should be on your shoulders. When you go to lift the patient, you want them to move as a unit. If their hands are not on your shoulders, when you go to lift them, their upper body is going to kind of go backwards like this, lean back. And that puts them off balance and can result in a fall. So their hands on your shoulders. So we're going to remove any obstacles before we walk the patient. We're going to put the gait belt on, check it with 4 fingers. We're going to make sure their feet are flat on the floor, count to 3, stand them up using the right body mechanics. Ask if they're dizzy, walk 5 steps, turn around, come back. Ask them if they can feel the chair behind us, and then we'll help them sit and remove the gait belt. Okay? Good. Gait belts go over clothing. I don't know why I have to tell you this. I don't know why this is an issue, but they go over clothing, not under. We're going to hold the gait belt on the sides or the back. Never pull somebody from the front. Don't hold the gait belt here and try to pull them. We want to be at the sides or at the back when we lift. Do you see how this patient's arms are at their side? Do you see how they're leaning backwards? This is a fall risk. This is why we want those hands just laying, not around the neck, not holding on, just laying on the shoulders. That keeps this patient in an upright position. Good. When you're walking, that patient should be just slightly in front of you and to one side. Your entire focus should be on that patient, not anything else. I've heard a lot of CNAs say, yeah, we were just walking and next thing I know, they're on the floor. Well, that tells me you weren't paying attention, because patients don't just walk along, I'm fine, I'm fine, I'm fine. Ugh. It doesn't happen like that. They get pale, sweaty. They slow down. They get woozy. They start to wobble. They put a hand here. They put a hand here. They put a hand out to the wall. They get unsteady. They have given you a million clues that something is not right here. You missed all of them. So where was your attention? Probably on your phone. Probably on the TV at the end of the hallway, talking to another CNA. You weren't paying attention to the patient. This is a risky operation. Do not multitask. This patient, do you want your surgeon multitasking? This is not the time to multitask. This patient needs 100% of your attention, period. Most falls happen during ambulation or transfers. This is the time you need to be paying attention. Monitor how they feel throughout the skill. Are you dizzy? You feeling okay? And then we're going to help them sit using that gait belt so that they don't just thump. We don't want injuries. We're going to remove that gait belt. When we remove the gait belt, you don't want to pull it against the skin. So this is, let me show you, Jake will need a close up. So I'm going to show you how to put a gait belt on. It does not matter whether the buckle faces this way or the buckle faces this way. Nobody cares. It does not matter. Okay. What matters is the tag is on the inside like every other article of clothing. So this goes around the patient's waist, not their chest, their waist. You put it around the patient's waist, making sure it's not twisted at all. You want it flat. When you put it around the patient's waist, you take the free end and you put it through the first guard by the alligator teeth. Yep. Please. A little more? A little more? Yeah. Okay. Do you see this? Do you see this guard and these teeth? Thank you. Okay. See the teeth and the guard, right? What we want to do is put this free end through the guard by the alligator teeth. And then we're going to pull it the way the teeth are pointing. See how all those teeth are pointing that way? We're going to pull it in that direction. And you want to pull it until we get it snug. And then we're going to fit 4 fingers between the belt and the patient. Once you've got it snug enough, then you're going to take this free end and you're going to put it through the second guard way over here and pull it until it's locked in place. Now this tail hanging down might be in your way if it's too long. So we're going to take that tail and just tuck it into the belt to get it out of our way. Now, when we're going to remove the belt, when we're ready to remove it, the way that we remove it is just a little bit different. You're going to take it out of the second guard. That's fine. But to remove that, remember to tighten it, we pulled the tail. To remove the belt, you just hold the tail still. Don't pull the tail. If you try to pull it, it's not going to work. This time, we're going to slide the buckle. So to tighten, we hold the buckle and pull the tail. To loosen, we hold the tail and pull and slide the buckle. Okay, and then you remove it from the guard. Now, once you have this unhooked, do not pull it against the skin. Listen to this sound. Do you hear that? That's going to cause a skin tear or burning. So we don't want to pull it against the skin. We're going to loop up and over, or you can reach around to remove the belt, but don't pull it. Good? Good? Okay. All right, so once we get the patient back to the chair and we've removed the gait belt, just make sure they're sitting appropriately, that their hips are against the back of the chair, that they look comfortable. So now that we know all of our steps, let's see how we're going to use them to check off this checklist. We're going to follow our care plan, and it says just to walk at least 10 steps. So 5 steps in one direction, turn around 5 steps back. Remember, we have 5 minutes to do this skill. We're going to do our opening. We're going to evaluate if we need gloves. If your patient is fully clothed and holding onto all of their own body fluids, you don't need gloves for this. We're going to use our shoe rules. Remember, we have to make sure the patient's shoes are on, their feet are flat on the floor. We use the right body mechanics when we're lifting. We're going to follow our Ambulate rules, and we're going to do our closing at the end. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Here's your call light. Environment's clean. Bed's in low position. Open the curtain. Wash my hands. Good? Okay. This care plan is only for this guy. Nobody else. Everybody else gets a different care plan. This guy, we're probably walking around the nurse's station 3 times because he's getting ready to go home. It's not 10 steps. It's 3 times. This lady, she needs a walker as well as her gait belt. This lady here, she walks on her own without our help. She is free and running and doing her own thing. This one is the only one that this care plan applies to. Good? All right, let me show you this video.
Hello.
Good afternoon, Mr. Jones. My name is Patty, and I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. Do you feel like going for a little walk?
Yes, that'd be lovely.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. I'm going to clear the walkway of obstructions. We'll close the privacy curtain and wash my hands. Now that I have clean hands, I'll get the gait belt. Mr. Jones, I see you have non-skid footwear on. Does it fit appropriately?
Yes.
Very good. This gait belt I'm going to put around your waist. It's going to help me lift you to a standing position and provide a little stability as we walk. Is that okay?
Yes.
Okay, I'm just going to slide this around your back. Okay, and lift your arms and relax. We're going to put the free end through the first guard by the alligator teeth and pull it so that it tightens the belt. We want the belt to be snug. We want to only be able to fit 4 fingers between the belt and the patient, and then we'll lock it in place by putting the free end through the second guard. And then we'll place the free end through the top just to hold it in place. Okay, Mr. Jones, your feet are together. In just a few moments, I'm going to have you place your hands on my shoulders, and I'm going to place my hands around your back. And on the count of 3, we're going to stand together. Okay?
Okay.
So I'll put 1 foot in front of your feet to keep them from sliding out, 1 foot beside the chair to keep me at an oblique angle. Go ahead and put your hands up here. And on the count of 3, we're going to stand. 1, 2, 3. Thank you very much. Are you dizzy at all?
No.
Okay, so at your pace, when you're ready, I'm going to have you lead and we're going to walk to the wall. I'll walk slightly behind and to one side, watching the patient. Okay, and go ahead and turn. And then we're going to walk back to the chair. Are you dizzy at all?
No.
Very good. So when you get to the chair, if you can turn around for me and back up so that your knees hit the chair, come my way just a little bit. And on the count of 3, can you feel the chair behind you?
Yes.
You're going to place your hands on my shoulders. Go ahead. I'm going to put 1 foot in front and 1 foot beside. And on the count of 3, we're going to lower. Ready?
Yes.
1, 2, 3. Being careful to bend at the knees and not the back. I'll remove the gait belt by taking it out of the second guard and then removing it from the first guard. We're going to remove it by looping it over the patient, being careful not to let any part hit the patient. And are you comfortable?
Yes.
Could you slide back so that your hips are against the back of the chair? Very good. I'm just going to go put the gait belt away. Are you comfortable, Mr. Jones?
Yes, ma'am.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your environment is clean. I'm going to hand you your call light. Here's your call light. If you need anything at all, just press that red button and somebody will be happy to help you. I'm going to open your curtain and wash my hands. After washing my hands,
I'll review the care plan, make any corrections that need to be made, and then tell the evaluator my skill is done.
I know that. I see your videos.
Good. You're welcome. Okay, for the next skill. Give me just a second, guys. There we go. All right, for the next skill, which is partial bed bath. This is a long skill. This is the longest skill we have on the state exam. If you look at the introduction page on page 126, down here, you'll see that somebody with your level of experience should be able to do this in 19 minutes or less. That's a long skill. It's not a hard one, though. You know everything you need to know. We know to follow the care plan. We know to do the opening. We will need gloves for this one, and I'll tell you why in a minute. We know to use a barrier on our table. We know to use a privacy blanket because our patient is going to be undressed. We know linen rules. We know to keep the patient in the middle of the bed. We know washing rules. We know how to clean the basin, and we know how to do the closing. We know all this. You'll see that this skill is going to be done on a mannequin, not a live patient. The mannequin will be in bed at the beginning of the skill. So if you go to page 127, we have the care plan at the top. We've got step-by-step instructions here. That's going to continue on to page 128 because there's a lot of steps here. Supplies are at the bottom, and there are a lot of supplies. You need to learn your supplies. Now let's take a look at the care plan. It says, give the resident a partial bed bath and back rub. Partial, that means not full. It means we're only going to be washing some of the body. We don't know what some of the body the nurse wants us to wash, so they've got to tell us. So it says, wash the resident's face, neck, chest, abdomen, back, and one arm and hand. What if the patient has two?
One.
Yeah, we don't care. We're going to wash one. It says with soap and water. So we're just going to use soap and water. Provide a brief back rub with lotion and dress the resident in a hospital gown. Patient is lying in bed and lying on back and center of bed and can roll as directed, but is too weak to assist with bathing. So we are going to wash. I'm going to shortcut this for you. Face to waist, front and back, one arm and hand. We're not going below the waist. Why? Because the care plan didn't tell us to. We're going to wash what the care plan tells us to and no more. So face to waist, front and back, one arm and hand. And that's just to reduce the time for this particular skill. They've already got it at 19 minutes. If you had to wash both arms, now we're at like 22 minutes. Okay?
I have a question about the care plan. This is like simulating the care plan, right? For the test. Because when I never work in a nursery home, but there the care plans are in the rooms, or where do we get the care plans from?
Okay, so turn in your book to page 115. And the answer to this depends on where you work. Okay? If you work in a nursing home, your patients don't ever change. Sally is the same today as she was last week, right? You have the same patients, you have the same schedule, you do the same tasks on the same days. Everything is very static, very regimented, routine oriented, right? So when you go into work at this nursing home, the person going off shift that you're taking over for is going to tell you a little bit about your patients. Sally is fine. Nothing new going on with her. Just do everything that we normally do. But Jack, he fell yesterday. So we are doing vital signs every 4 hours on him. Okay. So that's called a shift report, where you're getting information about the patients that you're taking care of from the person leaving the shift. Make sense? But in long-term care, very rarely is anything going to happen, going to change. So you're going to get a sheet like what you see on page 115 at the bottom that shows you, what we're going to do with each patient, and it will probably be printed. You'll just get it at the beginning of every shift. Now, if you're in a hospital, your patients are not the same day to day. In fact, you're probably going to start the shift with 6 patients and end the shift with 7 patients, and they're not the same. Because we had one goes to surgery, one was transferred to ICU, 3 were discharged, and then we got some new admissions. Things are changing all the time. So nothing's going to be printed. When you get information from the people leaving the shift, you're going to write it all down on a piece of paper, and you're going to make notes as you go so that you can give information to the next shift coming on. Okay. So in some cases, your report sheet, which is going to be it's taken from the care plan, it's information given to us. Some cases it's printed when your patients are very stable. In some cases, you're going to be writing all this down, getting the information from the person going off shift. Nurses will also, in the middle of all that, tell you, hey, I need you to go give a partial bed bath in room 212, right? So things are constantly shifting and moving. It depends on the setting that you're in.
Yeah, I was thinking, like, where do I get the care plan from?
Yeah, the information to take care of each patient is going to be relayed to you at the beginning of the shift. Okay. Good. All right. We know everything we need to know to do this skill, except for one step. This is the one thing I have to teach you. We know washing rules. We've learned that, right? Basins are no soap zones. We use a paper towel to turn our faucet on because the faucet is not clean. We test the water. It should feel warm, not hot, not cold. We ask our patient to check the water to make sure it's comfortable. Whatever we wash, we rinse. Whatever we rinse, we dry. If the water gets cold or soapy, we're going to change it. We're going to try not to get our surface wet by protecting it. And if we put lotion on, we warm it up and then we wipe off the excess. We know all of that. But there is one thing that we haven't covered in washing rules, and that's what we're going to focus on now. And it's called the leaves method. So I handed out washcloths to everybody. Those of you playing along at home, just go get a washcloth. So these are normally folded in half and in half again to make a small square. We have these in our linen closets, at home. And instead of looking at it as a square, I want to turn it a quarter turn and look at it as a diamond. Okay, so instead of being a square, we're going to make it a diamond. But when I position the diamond, I want it positioned so that the free corners are at the top. The free corners are at the top. Good? Good. If I hold this in my hand in a diamond shape with the free corners at the top, and I tuck in one side between my thumb and one side with my pinky and hold it like this, I can wash something with this. And then I can fold it over, and that traps the contamination underneath, and now I have a new cleaning surface. I can fold that over, trapping the contamination underneath and giving me a new cleaning surface. I can fold that over, trapping the contamination underneath and giving me a new cleaning surface. And I can even fold that over and give myself a new cleaning surface there as well. This is called the leaves method. And we use this anytime we're washing the eyes, the nose, the mouth, the genitals, the rectal area, wounds, rashes, sores, and incisions. So any body opening. Remember, body openings let things out, but they also let things in. So we want to make sure that we are using a clean area of the washcloth anytime we wash a wet body opening. Good. Now, remember, our care plan has us washing the face. Our face has wet body openings here, here, and here. I don't want to use the same area of the washcloth to wash all of that. So I'm going to use that leaves method to wash one eye, fold it over, wash the next eye, fold it over, wash the face, fold it over, wash the nose. I do the nose last because boogers, you know. Okay. Good. This is what we call the leaves method. So each leaf, 1, 2, 3, 4, is going to wash a different area of the face to prevent cross-contamination. So this is just a picture showing. We hold the washcloth with the free leaves at the top. We wipe something and then we fold it over. Then we wipe something and we fold it over. And then we wipe something and we fold it over. And then we wipe something and we fold it over. And if we need to, we can use the back to wipe something. Okay, good. Now we know everything we need to know to do this skill. Let's look at the skill specific steps now. So our care plan gives us very specific instructions on what to wash. The face, neck, chest, abdomen, back, and one arm and hand with soap and water. So we're going to shortcut that to face to waist, front and back, one arm and hand. We want to wash the face first and no soap on the face. No soap on the face. Soap dries the skin, gets into the eyes and can sting. So just water on the face is all we need. So we're going to wash the face first using that leaves method. So remember our leaves method. So I'm going to hold the washcloth, controlling it. So I don't make sure I wrung it out really well. Don't want drippy wet washcloths. I don't want floppy washcloths either. So I want to control this. So wring that washcloth out thoroughly. I'm not going to put soap on there. Where's my face again? Hold on. There it is. I'm not going to put soap on there. No soap. Wring it out. I'm going to wash inner to outer corner on one eye. Fold it over. Inner to outer corner on the other eye. Fold it over. I'm going to wash the face and around the mouth. I'm going to fold that over. And then the last one, I'm just going to wash the nose. And then this has body fluids on it. I can't reuse it. I'm going to set it aside on my barrier. Now I've rinsed. So what's the next step? Dry. So I'm going to get a towel and dry all of those areas. Then I'm going to get a new washcloth, wring it out really well. Wring it out really well. And then I'm going to wash neck to waist. So I'm just going to under the neck, behind the ears, across the neck, chest, down to the tummy, up the side, down the arm, hand, up the back of the arm, armpit last. Right? You don't want to spread armpit stuff everywhere. One washcloth. Yeah, one washcloth. Absolutely. Think about how you bathe. Do you use a different loofah for every body part? No. You get in there and you wash. Usually top to bottom, right? Save the dirtiest bits to last. Good? Makes sense? So one washcloth is all we need here. Okay, so neck, chest, abdomen, side, arm, hand, underarm, armpit last. Now, that had soap on it. I didn't use the leaves because there's no wet body openings here, just a washcloth. Set it aside. It's got soap on it. Now I'm going to get another washcloth and rinse it out. Wring it out. Wring it really well. And I'm going to rinse the neck, the chest, the abdomen, up the side, down the arm, the hand, up the back of the arm, and armpit last. But I didn't put soap on that one. It was just a rinsing washcloth. I can reuse that one for later. So I'm going to put it back in the water to keep it warm because I didn't put soap on it. Anything with body fluids, can't reuse. Anything with soap on it, can't reuse. But if it's just a rinsing washcloth, you can reuse it. Good? Good? Okay, so we're going to set washcloths aside on the barrier. And then we're going to turn our patient over. We're going to wash the back, rinse the back, and dry the back. Go ahead, read your care plan. Face, neck, chest, abdomen, back.
They said, oh yeah. I thought it was only a brief back rub with lotion. I thought, the back didn't include the back.
Yeah, it says to wash the back.
Yes.
Remember, we follow our care
It
plan.
include the back in one arm.
Okay.
It failed.
So we're going to wash the back, we're going to rinse the back, and we're going to dry the back. Now, in the middle of the skill, if you can't remember, go look at that care plan. You can look at the care plan in the middle of the skill. It's okay.
For example, if I finish doing, I'm in the test, and I didn't do the back, like wash the back. I just do the rub. I finish with everything, and I read it, and I realize that I missed the back.
You would have to
would
go
say-
back and wash the back. Correction, correction, I didn't wash the back.
Forget the back.
Because they need to see that you're not just going to wash it, you're going to rinse it and dry it too.
Okay, but I have to grab it again, or just,
No, you already did that. That's fine. Yeah.
I don't have to say correction if I didn't do the back.
I would, yeah. So they know that you
No, no,
understand
but
the
I mean,
order.
I have to do it.
Yes.
Oh,
Yeah, no, you're going to have to do it. Okay, and then we're going to give them a brief back rub with lotion. So we use our leaves method on the face only. That's the only time you need the leaves method for this skill. The leaves method on the face, then dry. Then wash neck to waist, one arm and hand, armpit last. Put that washcloth aside. Rinse all of those areas. Put that washcloth back in the water. Dry all of those areas. Everybody with me so far? Okay, now we're going to time out for a second. I know that you've got to turn the patient over to do their back. I know that. I got it. But you also have to put a clean gown on this patient after you wash them because our care plan tells us to put a clean gown on the patient. Good? If you put a clean gown on the patient when you're done with the front, you've washed the front, you've rinsed the front, you've dried the front, dress the front. Now, when you scoot the patient towards you and roll them on their side to wash the back, rinse the back, dry the back, and give them a brief back rub, all you have to do at the end is tie the gown. It's easier. Okay? It cuts a step. Because if you don't do that, if you leave your patient naked and you turn them on their side to do their back, they're going to feel exposed. But also, now you got to put them back on their back to get them dressed and turn them back on their side to tie the gown and put them back on their back. And that's a lot of energy for that patient. Remember, energy conservation is a thing. So finish the front, dress the front, turn them over, and then start the back. It's not a graded checkpoint. If you forget, it's okay. You can put the gown on at the end. But it's preferred to do it this way because of energy conservation. Are you starting to see how these skills kind of build one on top of another? That something that we learned earlier today is going to apply to this. This is why I teach you in this order. It may not make sense to you at first, but I'm doing this so that we're building on principles each day. Okay? That way you're more likely to remember them. All right, so now we know all the steps. There's a lot of steps here. I get it. And this is our checklist. A lot of steps there too. But we can get this checklist checked off by following the care plan. Look how many points we're getting for following the care plan here. We're going to do our opening and get all of those points. We're going to wear gloves for this and get those points. We're going to use a barrier and get that point. By the way, we want to protect the sheets for this, so I am going to put a towel under her while I'm washing her as well. We're going to use a privacy blanket. We're going to follow our linen rules, nothing on the floor. Nope, we're not going on break, sorry. We're going to keep our patient safely in the middle of the bed at all times. We're going to use our washing rules and our basin cleaning rules. So are you starting to see all of those principles that we already know are making up the majority of our steps here? And then we get to our skills specific steps, and that's all you're getting for this skill. Remember on Denture Care, it was almost all skills specific. This one is very few skills specific. It's almost all principles that we already know. And then, of course, we're going to end with the closing. This care plan is only for this patient, not for this one, or this one. They got their own care plans. This one gets in the shower. This one bathes herself. And this one, we do a full bed bath on. This care plan is only for this patient. Good? Okay, so we're going to watch this video. This is a long video, guys. Good morning, Miss Jones. My name is Patty. I'm your CNA today. How are you? Fantastic. I'd like to provide a partial bed bath. Is that okay? Wonderful. I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. Now that I've washed my hands, I can gather my supplies. I'm going to place the supplies on the overbed table. We'll start with a barrier, unfolding the barrier so the absorbent side is facing up, and this gives us a clean place to put our clean supplies. For this skill, we're going to need 2 towels, 4 washcloths, 1, 2, 3, and 4. I need a privacy blanket and a clean gown. Being careful not to hold the clothing against your uniform. I'll bring this over to the patient area. We'll bring this over here within reach, and then I'm going to get the supplies out of the drawer that I need. We're going to open the middle drawer and remove the basin, soap, and lotion. I'll put these on the overbed table. And I'm going to get a set of gloves. Okay, Miss Jones, I'm just going to get some water in the basin. I'll be right back. I'll use a paper towel to turn the faucet on. Check the water temperature with the inside of my wrist. It should feel warm, not hot, not cold. And we'll fill the basin about a quarter of the way full. Okay, Miss Jones, I have the supplies here. Would you like to check the water temperature and make sure it's okay? It's good? Very good. Okay. So I'll put the washcloths in the water. And the first thing that we're going to do is place a privacy blanket over you. This is going to help keep you warm and provide privacy while we do this skill. We're going to spread this out without snapping it or shaking it. Placing it over the sheet. And I'm going to pull your sheet down to just below your waist. Okay, now I'm going to put the towel on the bed. This is going to help keep your sheets dry, and will untie your gown. So I'm going to help you sit up by putting my hand on your upper back, and on the count of 3, we're going to sit. 1, 2, 3. Very good. I'm going to untie your gown. And then we'll spread that towel out underneath the areas that we're going to wash. Come on back. Very good. And I'm going to remove the gown on the side closest to me, supporting at the elbow as I lift. Okay, Ms. Jones, go ahead and bend your elbow. Thank you. And then we'll move the gown over to the other side, making sure that you're covered at all times. Now we're ready to start washing, so I'll go ahead and put my gloves on. We'll take the first washcloth, wring it out really well, and then I'm going to hold the washcloth in my hand so the free leaves are at my fingertips, and tuck in the 2 side corners. And this allows us to use a different leaf for each area that we're going to clean on the face. After wringing out the washcloth, no drippy wet washcloths, we're going to wash your face first. I'll start with your closest eye, and we're going to wash inner to outer corner using the leaves method, which is going to help prevent cross-contamination. So with the first leaf, we're going to wash the inner to outer corner of this eye. We'll fold that leaf over. And with the second leaf, we'll wash the inner to outer corner of that eye. Fold that leaf over. And with the third leaf, we'll wash the remaining skin of the face. We'll fold that leaf over. And with the last leaf, we'll wash the nose. And we're going to put this on the barrier. Whatever we rinse, we dry. So I'm going to take the towel and fold it around my hand so I have control over it. And I'm going to pat all of those areas dry using short, soft strokes or a patting motion. We'll set the towel aside. Okay, now we're going to take washcloth number 2 and wring it out really well so that it's not drippy wet. And then we'll apply soap to the top leaf. We're going to start cleaning the neck, behind the ears, under the chin, across the neck, the upper torso, down to the breast, keeping the patient covered at all times to protect modesty, down to the belly button, and up the side. Now, for the test, you will keep the patient covered. The evaluator will ask you to move the blanket if they would like to see. I'm going to go ahead and remove the blanket now so that you can see what I'm going to do. So we're going to move the blanket down, and I'm going to start again to show you how to clean the patient. So under the chin, behind the ears, across the neck, the upper chest, around the breasts. When you lift the breasts, we lift not with the palm, but with the back of our hand to lift the breast to clean underneath, down to the belly button, up the side, down the front of the arm, all the way to the hand, supporting the elbow at all times, either with your hand or the bed, up the back of the arm, and we'll clean the armpit last. We're going to set that on the barrier. Whatever we wash, we rinse. So I'm going to get a rinsing washcloth, and we're going to rinse all of those areas the same way. So behind the ears, under the chin, across the neck, upper torso, around the breasts, down to the belly button, up the side, down the shoulder and the front of the arm, supporting the elbow, the hand, lifting the arm from below, washing the underside of the arm and the armpit last. We'll set that washcloth back in the basin for future use. We're going to take the towel, controlling the edges, and we're going to pat all of those areas dry or use short, soft strokes. Nothing vigorous. So the abdomen, down the arm, lift the arm up, support at the elbow, dry the hand, lift the arm to dry the underside of the arm and the armpit. We'll set this aside. Now, the care plan only asked us to clean one arm. So we don't have to go over and clean the other arm. And that's because that's what the care plan instructed. In some cases, you will have to clean both arms. In that case, you would just do that at this time. But for right now, we only had to clean one arm. We did that, so we're going to dress the resident in her gown. I'm going to spread the gown out, put my hand in through backwards on the armhole, lift her hand by holding her fingers together to place the sleeve over the arm, and then I'll lift at the elbow to bring the gown up. I'm going to make sure that gown is covering her. Put the privacy blanket back in place, and now I'll go to the other side of the bed to remove the old gown and put the new one on. Okay, now I'm going to move the blanket and remove the gown from this arm by sliding it off the arm, lifting the elbow from below with a flat palm, and then this will go in dirty linen. Now I can put the new gown on this arm by putting my hand in through the armhole backwards, grasping her hand, and sliding the gown over. We're going to lift from below at the elbow and make sure that the gown is properly in place. Now I'm going to go back to the other side of the bed. Okay, Miss Jones, I'm going to wash your back now. So I'm going to pull you toward me and turn you up on your side, and that way you're in the middle of the bed after the turn. Okay, go ahead and slide toward me. And then you're going to roll on your side. 1, 2, 3. Thank you very much. The evaluator will hold the mannequin in place during your cleaning, during the test. Live patients, of course, can lay on their side. So I'm going to ask the evaluator to please hold the mannequin in place for me. Thank you. We'll slide this towel down so it's covering the bed underneath the back. We're going to take our third washcloth, wring it out really well, and we'll apply soap to the top leaf. I'm going to wash the back from the neck down to the shoulders, all the way down to the waist. We'll set this washcloth aside, and we'll get our rinsing washcloth. So we'll wring that out, and we'll rinse the same way we washed. The back of the neck, the shoulders, all the way down to the waist. We'll set that aside, and we'll take our towel to dry those areas. So I'm going to pat dry or use short, soft strokes and dry all of those areas. Now the care plan asks me to provide a brief back rub. So I'm going to take my lotion, put a little bit in my hands, and then I'm going to warm it up by rubbing my hands together. We're going to start at the base of the back and go up in small circles to the shoulders, and we'll do this 3 times. To the shoulders, come down, up to the shoulders and come down. And then we'll take the towel and wipe off the excess lotion. We'll remove that towel from the bed, putting it on the overbed table, and then we'll tie the gown. Come on back, Miss Jones, onto your back, and then scoot to the middle. Thank you. Okay, you're covered and safely in the middle of the bed. Let me go dispose of all of my supplies, and I'll be right back. So I'm going to put all of the supplies in dirty linen, being careful not to hold them against my uniform. And now I'm going to clean my basin, and we'll dispose of the water in the sink. rinse the basin, and then dispose of the rinse water into the sink as well. I'm going to set that down, disinfect it per facility policy, and then pick it up with a paper towel. I'm going to get a clean paper towel to dry the inside. I'm going to get a clean paper towel to dry the outside. And then one more for the drawer. Okay, on the way, I'll place the lotion and the soap into the basin using a paper towel. And then I will use the paper towel to open the middle drawer and slide the basin with the soap and lotion into the drawer. We'll close the drawer with the paper towel and then throw them away. I'm going to remove the barrier, throw it away, and then I can remove my gloves. Okay, Ms. Jones, I'm going to move your privacy blanket now. So as I pull the blanket up, I'll restore the sheet. This preserves modesty and keeps the patient warm. We'll roll the privacy blanket up in a ball so that trailing edges don't contaminate other surfaces. Okay, I'm going to place this in dirty linen. We'll return the table to storage. Adjust the sheet for neatness and appearance. Okay, Ms. Jones, are you comfortable? Is there anything else I can get for you while I'm here? Okay, let me place the call light in your hand. So there you go. The call light is in your hand. If you need anything at all, please press that red button. We'll be happy to come help you. Bed is in the low position. The environment is clean. I'm going to open your curtain and go wash my hands. After washing my hands, I'll review the care plan to make sure that everything in the care plan was addressed with this skill. I'll think about my skill and make any corrections that need to be made. And once I'm happy, I'll tell the evaluator my skill is done. Okay, any questions on that? Homework tonight is chapter 7 in your reading. It'll be the questions on page 187 in your white book. You'll get your wrap-up email today as well. CPR, we haven't really talked much about. CPR is not required for the test. It's not required for the class, but you will need it to work. So if you do not have CPR for healthcare providers, what we call BLS, Julie does a class. This is actually her classroom. So Julie does a class here. If you use that QR code, it'll bring up the schedule and you'll be able to register with a coupon code, but only through that. It's also on your first day blue sheet as well. Jake already handed out the review sheets for you. So congratulations, you got through another class. Only 3 more to go after this.
I'm sorry, I have just one question.
Sure.
Sorry. Just one question before we go. The washcloth, there were 4 washcloths, and
So we wash the face and put it aside. We wash the torso, put it aside. We rinse the torso back in the basin. Because anything you don't apply soap to can go back in the basin. We turn the patient over. We use that one, put soap on it to wash the back, and then the 4th one to rinse the back. You can use 5 washcloths for this on the state exam. So you can grab 5 if you want. That's fine. I want you to know how to do it with 4 because in most settings, you're not going to have enough supplies. You need to know how to use 4.
and in the test, the barrier is going to be the same barrier that you have here? Okay.
Yep.
Because we can use a barrier, any kind of barrier in different places that we work.
Right.
But for the test,
It'll be
we'll
that.
use the same one.
Yep.
Okay.
Yep.
Just make sure. I don't want to be like, what can I use this barrier?
Yeah. No, they'll use the same. Everything we have here is what they use in the test. All right, you will have some practice time at the end of class on Wednesday. Okay. All right. Well, congratulations on making it through another class. Only 3 more to go. If you haven't registered for the test yet, you might want to make that a priority. Until next time, happy caregiving. Bye.